Good morning, everybody. This is Deanna Parrish. I was the one that was talking behind the scenes just now. I am the development director for the Parkinson's Foundation Carolinas chapter, so you can call me the Carolina girl. I work throughout the Carolinas, and I work with probably 50 great volunteers, many who have helped organize this 3-hour symposium. This has taken us about 4 months. We've met a lot, and we really were trying to figure out what is the greatest presentation or meeting your needs in Eastern North Carolina. And we really think today, after 3 hours, we hope that you leave feeling empowered. The program today is in collaboration with East Carolina University. We are so grateful to them, and Kathrin and Jennifer have been serving on the committee. We couldn't do all this, all our work. We need sponsors. So we are so grateful to the 6 sponsors that have come on board with all our educational symposiums in the Carolinas chapter, and that's Amneal, Synovian, Koetter, Acadia, Supernus, and Koetter. If you want to learn more about how Amneal or Koetter, what it is that they do that helps people with Parkinson's, in the chat area, we just gave you a link. And then if you go to parkinson.org/Carolinas, just click on chapter supporters and click on their logos, and it will take you directly to the product that they have that helps people with Parkinson's. Next slide. I joined the Parkinson's Foundation in June 2018. Prior to that, I was a volunteer leader because my husband has Parkinson's disease. The resources and what the Parkinson's Foundation, their primary focus is research and taking care of people with Parkinson's. In essence, people living with Parkinson's, so that their journey, they live a quality life. My husband has been beating it for 15 years. I know others, when you have the resources, there are quite a few of them, you can beat the disease and you're not alone. Next slide, please. The Parkinson's Foundation, what I love about them is that there are so many free resources. We have books, Coping and Caring, Mood, Cognition, a lot more. We have the Aware and Care Kit, which is critical for people with Parkinson's when you go into the hospital. 2 Aware and Care ambassadors actually served on this planning committee. We have a helpline, 20,000 calls a year. The helpline is 1-800-INFO-4PD. If you have any questions, call the helpline. And we also have Spanish-speaking staff members to help with the helpline. Next slide, please. Everyone, our life shifted. It's been over a year now that we very quickly turned to a virtual world. I believe that many of us believe that this virtual reality is going to be happening for a while now. So the foundation did an excellent job at shifting to virtual, as today is an example. Typically 2 years ago, we would have been in person, but we have quite a few offerings through PD Health at Home, Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. Please look at the foundation's website and take a look at these programs. We've had thousands participate virtually in these programs. Next slide, please. PD Generations. Okay, this is very exciting. In 2019, the foundation launched PD Generations. And what it is, mapping the future of Parkinson's disease. We provide at no cost to people with Parkinson's free genetic testing. In addition to the testing, and this is critical because when you get the results, you don't know what it means. We provide at no cost counseling, so they will interpret the genetic test. So if you would like to sign up, if you have Parkinson's, you can visit parkinson.org/PD Generation to sign up for the free genetic test. Due to COVID, the Parkinson shifted, and it will be mailed to you at home. So you don't have to go in person to do the genetic test, but you can learn a lot more on our website. This will really help with research. So we're real excited, and our goal is to have 15,000 tests done by 2025. These tests normally cost the foundation approximately $2,000 per person. Next slide, please. Connect with us locally. I told you I'm the Carolina gal, and I told you about my husband. Well, that's Bubba and my two daughters. They're very involved as volunteers. This is Moving Day Winston-Salem, which are Moving Day events. If you haven't attended, for many of you, Moving Day NC Triangle in Raleigh on November 6th. Please come. We are doing everything we can to be in person. It's magical because you realize there are everyone is they're on the journey with you. So Moving Day is a phenomenal event to make you realize that you're not alone on your journey. We give out community grants. The foundation does. This year, we're going to give out $2 million. We'll find out the grantees in June. Educational programming, such as this one. Like I said, we worked for 4 months on trying to deliver to all of you in Eastern North Carolina. And I know we have guests from other areas, how to navigate the system. And we're fortunate in the Carolinas to have 3 centers of excellence. Duke, UNC, and Medical University of South Carolina are recognized as the top health institutions that provide the continuum of care, where they have the occupational therapist, physical therapist, the social worker. And like I said, we're very fortunate to have them. Next slide, please. These are the Moving Day walks. We just hosted Moving Day Winston-Salem this past weekend. It was virtual, but I promise you, people did move, and they were moved emotionally. If you want to get an idea of what it's about, go to movingdaywinstonsalem.org. Our virtual event is still listed. You can go ahead and watch it. Next, we have Moving Day Charleston, May 22nd. Charleston is a place people love to go. So maybe, if not this year, we're going to do it April 2022. And then Moving Day NC Triangle, I told you about that earlier, November 6th. It will be from 10 to 1. Come join us. We're going to be in person, COVID protocol. We're going to follow everything, but we hope you join us. Next slide, please. Okay, Parkinson.org is the website for the Parkinson's Foundation. And here is the helpline number again, 1-800-4PD-INFO. The staff, the women and men that staff the helpline are amazing. And if they don't know an answer, I promise you, they really do seek it, and they'll get back to you. Next slide, please. Okay, at this point, it is my pleasure to introduce to all of you one of our committee members, and many of you probably know Dave Mauney from Oriental. Dave is one of our Aware and Care ambassadors, but he's going to share with all of you why we're here today.
Welcome. On the behalf of the Symposium team, I would like to welcome you to Getting Expert Parkinson's Care in Eastern North Carolina. I'm Dave Mauney. I was diagnosed with Parkinson's 3 years ago. I, along with Diane Russell, have visited support groups across Eastern North Carolina as your Aware and Care ambassadors. I expect Diane and I have met many of you. Parkinson's is a complex disease with many symptoms. On top of that, we are all different. There are 2 problems for us in Eastern North Carolina. The first is that there are only 1 million people with Parkinson's in the US. That makes us less than 0.3% of the US population. Thankfully, right now, there are not more, but it makes it a difficult situation for those of us with Parkinson's and our caregivers. It is hard to find physicians and therapists who are specially trained in Parkinson's. Second, the population in Eastern North Carolina is lower than the middle part of the state. The population in North Carolina between the Charlotte area and west of I-95 is 4.5 times that east of I-95. This means that even fewer medical professionals specializing in Parkinson's are attracted to Eastern North Carolina. As a result, we must travel long distances to see medical professionals we need. In the East, this means Wilmington, Raleigh, Duke and Durham, UNC and Chapel Hill. These long trips from the East are difficult for us and our caregivers, especially during the time of COVID. We hope that what is presented in this symposium will give you ideas on how you can focus on your care, even though you're living in Eastern North Carolina. As you watch and listen to the presentations, I encourage you to notice the theme of how you can set your most significant symptoms to determine which Parkinson's specialist you need to have on your care team. Yes, we are talking about the concept of building a team because we have multiple symptoms. Think of the symptoms that affect your quality of life the most. This will determine which Parkinson's specialist you need to see and have on your care team. Both motor and non-motor symptoms will be covered. The second theme I encourage you to look for is how you can use telemedicine to attend appointments with Parkinson's specialists without having to leave your home. Because of COVID, telemedicine has really come into its own. It is well accepted in the medical community. We can take advantage of that. We're also going to look at the future plans for support of people with Parkinson's in Eastern North Carolina. Be encouraged. We're thankful you decided to attend this symposium. Thank you.
Thank you so much, Dave, and thank you for all the work and everything that you and Diane do in Eastern North Carolina to engage people with Parkinson's. It is my pleasure right now to introduce our first expert speaker, Dr. Jessica Tate, who is a movement disorder specialist at Wake Forest Baptist Health. And I do want to share with all of you, Dr. Tate is my husband's doctor. She and her team are amazing. So I talked about the centers of excellence, but we are very fortunate to have movement disorder specialists like Dr. Tate that help so many people with Parkinson's. Dr. Tate, take it on.
Thank you so much, Deanna. It's a pleasure to be here with you all today. I'm going to get my slide presentation. Oh, sorry. Just a moment. Okay, I apologize. So I'm going to speak with you a little bit today about navigating treatment for Parkinson's, and maybe some tips and tricks that might help you get the most out of your healthcare visits. And we'll talk a little bit about your treatment team, your care team, although I think there's going to be more depth on that later in the morning as well. So first, I'm just going to give some background on Parkinson's, just to bring everybody up to speed. So the key motor features of Parkinson's disease, and the things that a neurologist is looking for potentially on an individual's neurological exam, when they come in and have complaints that could suggest Parkinson's, or they have concerns about Parkinson's. The first core feature is what we call bradykinesia, and that's basically a combination of slow movements and a smaller amplitude, smaller size of movements. So an example is asking somebody to tap their fingers and seeing that movement is smaller than it should be, or that it kind of dies down in size. And bradykinesia kind of has to be present for us to make a confident clinical diagnosis of Parkinson's. The other main features, rigidity. So that's a muscular type rigidity. That's something that we can feel in clinic if we passively move a person's arm back and forth, or their leg back and forth. We can feel that resistance. Tremor is probably one of the more well-known signs of Parkinson's. That's something that a lot of people are familiar with. But I always emphasize, you do not have to have tremor to have a diagnosis of Parkinson's. It is an optional thing. When it is there, it's usually a very characteristic type of tremor. So it's what we call a resting tremor. It's there when a person's arm or leg is kind of completely relaxed and at rest. And it's usually a relatively slow frequency of tremor. And then other things that we're looking for that support, something being Parkinson's, is an asymmetric presentation. So most of the time at initial diagnosis, symptoms will be either confined completely to one side of the body or, unevenly involve one side more than the other. The other thing that, often requires a little bit of follow-up on our part with patients is assessing whether the person responds to the dopaminergic medications that we use for symptomatic treatment of Parkinson's. And, even though, and I kind of get to this later, there are many medications on the market for Parkinson's now, our gold standard still when we're assessing medication response is typically carbidopa-levodopa, which is also known as Sinemet and a couple of other brand names. A very important thing to keep in mind, though, is Parkinson's is much more than just motor symptoms. So there are also many what we call non-motor symptoms of Parkinson's. And these are a few, just as examples, but things like mood changes, depression, anxiety. And of course, those things can be situational. They can be related to somebody, receiving a diagnosis of Parkinson's and being worried about their future, and just related to their struggles with the disease. But there are real chemical changes, of course, that are taking place in the brain in Parkinson's, and those can increase the likelihood of developing depression and anxiety. Apathy, which is kind of a loss of interest or loss of motivation, to initiate activities or get things started. It can be frustrating. Sometimes family members or friends might perceive it as, oh, this person's become lazy. But again, it directly relates to, some of the areas of the brain that are impacted by Parkinson's. So it is, it's created from Parkinson's disease. Sleep disturbances are common, insomnia, what we call REM sleep behavior disorder, which is during rapid eye movement sleep, the phase of our sleep when we typically dream, our bodies are supposed to be kind of completely relaxed in a relaxed state. And in REM behavior disorder, they aren't necessarily. So people are able to move, kick, yell, talk, things that can be sometimes disruptive to a bed partner. So that's usually when it comes to our attention. Hallucinations or delusions. Those are things that kind of fall into the category of psychosis. And those aren't givens in Parkinson's that people will go on to develop psychosis, but it is a common symptom. Autonomic dysfunction, lots of things fall into that category. Bladder dysfunction, constipation, difficulty with blood pressure regulation, sometimes even abnormal sweating or abnormal temperature related symptoms. Fatigue can be a very frustrating symptom that people with Parkinson's struggle with, and sometimes even unintentional or involuntary weight loss. So, it's a multi-system disease, and it certainly creates more challenges than the classic motor symptoms that we think about: the stiffness, the slowness, the tremor. Again, just as a reminder, so the diagnosis of Parkinson's is still clinical at this juncture, meaning there isn't one test that, can be administered to confirm a diagnosis. So as neurologists, we base it on the history that someone's reporting to us, and we base it a lot off of their neurological examination and those specific features that I mentioned that we're looking for. In some very specialized situations, sometimes we'll obtain a scan called a DAT scan. And this is an image of kind of what that looks like to us after we obtain a DAT, and that looks for dopaminergic reduction in the brain. One example for that scenario would be somebody on certain medications, and those are typically what we consider antipsychotic medications, certain psychiatric meds, and certain nausea medicines that can kind of mimic or create symptoms that look like Parkinson's but may not be. And in a situation like that, if people are on a medication like that and are unable to discontinue it, then we may obtain a DAT scan. So that's just an example. But most of the time, we're diagnosing Parkinson's based on what we hear and see from the patient in clinic. So optimizing your care. So initial management of Parkinson's is relatively straightforward. And generally, if people are started on a medication early in their disease course, then their symptoms can be pretty well managed with a simple regimen. So maybe 1 or 2 medicines a few times per day. Sometimes that is initiated by a primary care provider. Often it's initiated by, a neurologist, a general neurologist. And, that's, I think, reasonable at that juncture. But as Parkinson's goes on and people hit what, the Parkinson's Foundation in their literature refers to as mid-stride Parkinson's, then things can get more complex and people can develop what we call motor fluctuations. And some of the things that fall under motor fluctuations would be wearing off of the medication too early before a person's due to take their next dosage, involuntary movements that we call dyskinesias. So those can look like kind of rocking or wiggling or writhing kind of movements. And those tend to happen more often at the peak of the dose. So as a dose is kind of kicking in or as it's, at its best and working, although it can get more complicated than that. And some people can develop dyskinesias as their medicine wears off. And then sometimes dose failures where a dose of Parkinson's medicine just never really seems to kick in. And when that begins to happen, again, the management coming up with the appropriate medication choices, I would say certainly you want a neurologist to be involved in your care at that point. I feel like that's a must. And that's also really when a Parkinson's specialist, a movement disorder specialist, can really be helpful. And I'll kind of go into some more information about movement disorder specialists. So what is a movement disorder specialist? So, first of all, a movement disorder is really defined as a neurological condition that causes people to either move too much, have excessive movements, or have a reduction in movements. And Parkinson's really is kind of a combination of both. Because you have, the bradykinesia, but then you also have symptoms like tremor and dyskinesias that are excessive movement. And a movement disorder specialist is a neurologist that has special training in diagnosing and treating Parkinson's, and not just Parkinson's, but other movement disorders, that you may have heard of, like essential tremor, dystonia, tics. So our training involves medical school, and then a 4-year neurology residency, and then additional fellowship training in that specialty area of movement disorders. And usually that additional training is 1 to 3 years. It can vary. My fellowship training was 2 years, and I completed it at Wake Forest Baptist Medical Center. So, why a movement disorder specialist? Why involve them in your care? Well, as I mentioned before, Parkinson's is a clinical diagnosis. And so we rely a whole lot on kind of recognizing, features and recognizing things that people report to us in, a history to point us in the direction of that diagnosis. And one challenging thing is that it overlaps with some similar diseases. So there's kind of this group of diseases that we label Parkinsonism, kind of this umbrella. And under that umbrella, you have Parkinson's disease, but then you have a group of diseases called atypical Parkinsonism, and they behave differently. There are lots of overlaps, but they behave differently. And so movement specialists see the most patients with those particular diagnoses and just probably have the most experience in differentiating the signs and symptoms that distinguish them from one another. We also have the most experience with the 15 plus medications that are now out there. And that's just the medications for motor symptoms. That's not including things for non-motor symptom management. So, just keeping up with the kind of specific roles and indications for those medicines can be, challenging. And we just, tend to have the most comfort, I think, and experience with using them. I think movement specialists typically can best evaluate and maintain some of the advanced treatment options, or have access to some of the advanced treatment options out there for Parkinson's, like deep brain stimulation and like the Duopa intestinal pump. And, at Wake Forest, for example, we have a DBS center. We have a multidisciplinary team, and we, implant the stimulators, and then we also follow patients for programming and just maintenance of the stimulators. And we may have access to, not to say that other neurologists or general neurologists do not have access to clinical trials, but in general, most movement disorder specialists are located at tertiary care centers, academic centers. And so there may be more of a tendency, for us to have active clinical trials or observational studies, which, don't necessarily change your management, but your participation adds to our knowledge about Parkinson's and, ultimately advances the science forward. So if there's interest in those, then often you can locate them with a movement disorder specialist. This is not a slide meant to be overwhelming, but this was just an example that I put together of those motor symptom medications. So these are all the possibilities that are out there on the market right now. And like I said, just kind of choosing when to use what for a particular set of symptoms, or, for a particular patient can be challenging, but that's what we do. This is just some data kind of supporting the role of, both movement specialists and neurologists in general. So there was a study in 2007 that compared just the assessment of kind of key issues that arise in Parkinson's by movement specialists compared to general neurologists compared to non-neurologists. And by far, both the movement specialists and the general neurologists, did a better job of being able to assess for these issues than a non-neurologist. So that would include like a primary care physician. And movement specialists were the strongest of the three at assessing a few specific areas of non-motor symptoms, depression and hallucinations. And those are symptoms: depression, hallucinations, and falls, all contribute significantly to quality of life for the person living with Parkinson's and also their care partners. And as I said, both movement specialists and general neurologists did well at assessing for wearing off, which is another, significant issue that contributes to quality of life, and assessing falls. There was another study that was a survey, kind of assessing satisfaction with care. And it surveyed a group of Parkinson's patients, and the people seeing a Parkinson's specialist were 3 times more satisfied with their care, and were more likely to attend a support group, which can be an important part of your care team. So the involvement of a movement disorder specialist, can vary quite a bit. So for some patients, I'm their primary neurologist. So I'm the only neurologist that they see. And often, those patients are going to be either local, so it's not a huge burden for them to, travel to Baptist Medical Center, or they are more complex. So again, they may be patients who have DBS, who have a deep brain stimulator. They may be patients that have a Duopa pump that just requires a little bit more, specialized care. But for some patients, and this is a big subset of my practice, I would say, I alternate care with a general neurologist. So this can certainly be helpful when my patients do live pretty far away. I think it's optimal to have a local neurologist, somebody who's more nearby if some type of urgent issue arises. It's much easier to see them than have to travel to see me. And again, I may focus on just a specific aspect of their care. So sometimes, patients' medications are managed primarily by their local neurologist, but I see them periodically to, check in on their deep brain stimulator or something like that. So we will typically alternate visits. That if you saw your local neurologist, at 3 months, then you might see me at 6 months or 9 months. And we handle it that way. And, that typically works out well. We just have to make sure that we're communicating with each other. So, if you do see 2 different neurologists, a general neurologist and then a more specialized neurologist, then you just need to make sure that they're communicating with each other, that they're sending each other copies of your records, of your notes. If there are medication changes, that they both stay up to speed on the medication changes, because that can be a challenge. If changes are being made and then, we're not aware. We do have telehealth options. So that was mentioned earlier. Yes, telehealth has really come of age. And so it's common for me now to check in with some of my patients, and especially the ones who, have a harder time getting out, who live further away. It's common for me to check in with them through a video or a phone call. And practices vary in this, but our particular practice, the Movement Disorders Clinic at Wake Forest Baptist Health, we only see our return patients via telehealth. So we really feel like for that initial visit, when we're getting to know a patient and we're getting to know the background, we really need to be able to kind of lay hands on the patient and do a full neurological exam. So that's our preference. What we would ask people to come in for that initial visit, and then subsequent visits after that might be, at least predominantly through telehealth. We also at Wake Forest Baptist Health, and, as Deanna mentioned, probably at the Centers of Excellence, we have a Parkinson's multidisciplinary clinic. So that means, a patient could come in one morning and they would see neurology, and they would see neuropsychology, who can do kind of cognitive assessments, and physical therapy, speech therapy, occupational therapy, and recreation therapy. And so, again, that's a good option for people, who may not have access to those things locally, to be able to get, comprehensive assessments by a bunch of different professionals at one visit. And, that would be something to, I think, inquire about. If you have if you're seeing a general neurologist locally, you could always ask for a referral, specifically, to be evaluated in a multidisciplinary setting. And like I said, that would apply to us at Wake, but that would probably also apply to the clinics at UNC and the clinic at Duke. So going back to non-motor symptoms for just a moment, so these are symptoms that may very well be related directly to Parkinson's, and that I think you should absolutely mention to your neurologist if you're experiencing them. It can be a challenge because, as I mentioned, Parkinson's can really cause some body-wide issues. It's not just a brain disease. But we also want to be careful not to chalk every, symptom or complaint that a person develops to their Parkinson's. We don't want to blame everything on Parkinson's, because that's not always appropriate. So having somebody to kind of talk through these things with is very helpful, because, your neurologist may be able to identify, should we be chalking this up to Parkinson's? Does that make sense? And if not, then, either kind of communicate that back to your primary care provider, or send you to another appropriate specialist in another area to help evaluate better. So here are examples of some things that might be related to Parkinson's and are worth bringing up, like I said. So sleep difficulties, and that can include things like the insomnia, and it can include the problem, the REM sleep behavior disorder, being overly active in your sleep, acting out dreams. That's usually something that a family member residing in the home or a bed partner are going to be more aware of. Depression, anxiety, So bladder dysfunction, like urinary frequency, urinary urgency, incontinence, constipation, lightheadedness. As I think briefly mentioned earlier, there can be issues with blood pressure regulation for people who have Parkinson's. And so sometimes that shows itself as, lightheadedness when a person stands up quickly or sits up. Hallucinations, certainly mention to your neurologist. And then this one is maybe one of the more challenging. So sensory changes like pain, numbness, and tingling. Occasionally those things can directly be chalked up to Parkinson's. Like, for example, some people have some discomfort when they wear off, when their medication wears off and they're in an off state. And in that case, I would directly chalk it up to Parkinson's disease. But a lot of times, pain or numbness or tingling may be related to some other issue. I mean, possibly a neurological issue, but not necessarily something to directly chalk up to Parkinson's. So that's where your neurologist, I think, can be very helpful in assisting you in sorting that out. So some of those symptoms would be likely directly treated by your neurologist. I mean, I know I certainly treat people initially for, sleep problems or attempt to, mood issues. I can initiate medications for those, or recommend that people see a therapist. I can make recommendations about constipation. But some of these issues, we may want another specialist involved. And it's relatively common that I would, recommend a referral or place a referral to a urologist, depending on the bladder issue, a psychiatrist. People have maybe tried multiple medicines and we're having more of a challenge managing mood. I would want the expert to be involved. Cardiologist, we talked about lightheadedness, depending on, blood pressure, heart rate issues, I might refer to a cardiologist. So a neurologist can help to coordinate, along with primary care, can help to coordinate, these team members. So optimizing your visits. So things that I kind of wish my patients knew, ahead of visits. So one is keep track of symptoms. So knowing the daily patterns. So, again, this applies more to people that are in sort of that mid-stage Parkinson's or beyond. If they're experiencing wearing off, if they're experiencing dyskinesias, if they're experiencing things like gait freezing, knowing kind of the timing or pattern of those is extremely helpful to your neurologist. If people come in kind of with those symptoms, but they can't tell me, when they're occurring, or they can't relate, any type of timing to their medications, and often they'll say to me, they're like, well, I haven't really paid attention to that. But having that information is really helpful for me to make decisions about their treatment, and about, potential medication changes or deep brain stimulation or something like that. Consider keeping a symptom diary. I mean, certainly doesn't have to be for every day. That would be overwhelming for you. That would probably be overwhelming for your neurologist, but for maybe 1 or 2 weeks before your appointments, maybe keeping track, like, okay, these are the times that I took my medication that day. These are the times that I noticed off symptoms. These are the times that I, was aware of dyskinesias. That can be really, really helpful. Know your medicines and why you're taking them. So, truly ask your doctor what to expect, because they're going to want feedback when you follow up. So if you go back and, they ask, well, did it help? And you're not able to, tell them what you observed, that can be a challenge. So know what benefits you should be looking out for when your doctor starts a new medication. And obviously, get information about what side effects you should expect too. If you're having challenges taking your medication on time, if you're missing doses or you're late on your doses, be honest with your neurologist about that. Because there might be some strategies that they can recommend, or there might be some other medication options that, may be easier for you. But please be honest about your struggle in, getting those medicines on time. Write down your questions before visits. I absolutely do not mind when people come in with typed lists or written lists of questions, because it kind of helps us flow through the visit and kind of, check those things off. And don't be uncomfortable asking for a second opinion. I mean, if you just really feel like you're not getting your questions answered, or you're just not comfortable with the relationship with your provider, don't be afraid to ask for another opinion. And I mean, that includes myself, if people request even another movement disorders opinion, that doesn't offend me. And then again, I think this is going to be touched on in more depth, but these are the people that it would be ideal to have part of your care team at one point or another through your Parkinson's journey. So obviously primary care is very important in kind of being the hub and coordinating all your care team members, but a neurologist, as symptoms become more challenging, a movement disorder specialist, physical therapy, occupational therapy, speech pathology, a psychologist, therapist, or counselor, a support group, being able to bounce things off other people that are maybe experiencing, similar issues, a trainer or exercise instructor. So programs like Rock Steady Boxing that are often based out of, community gyms and things like that. And even a palliative care specialist. And that just means, it's a person who, when a person has a chronic disease of any type and is dealing with, symptoms that impact their quality of life, a palliative care specialist can help manage some of those symptoms. And I want to make sure that I leave time for questions. So that's it for my formal presentation.
Thank you so much, Dr. Tate. We're going to get Dave, who's going to moderate today's Q&A session. We're going to get Dave on camera here in just a moment. But while we're working on that, just so that we don't skip a beat here, because we've had a lot of questions come in, I'll go ahead and ask you the first question, Dr. Tate. And by the way, that was a really informative presentation, so thank you. So we actually had somebody from a local support group. I know they had quite a few questions having to do with medications, primarily, various generic drugs, like basically generic Cinemet. Do you know, like in your experience, does it matter sort of who the manufacturer is of those drugs? And would that make a difference on how well someone tolerates the medication?
So my answer to that would typically be, no, we don't think so. There's not a specific brand that I've had a preference for, and typically, generics are less expensive in many cases. So we rely on those a lot. But I do have to say, occasionally I will have a patient come in and notice a difference. For example, when their pharmacist maybe, has switched them to a different generic brand, which is usually based on just either cost or availability. Sometimes those get switched. Of course, like if they're noticing a difference in their symptoms and how long it's lasting or how well they're tolerating it, then usually we'll just write a request to the pharmacist that it should always be filled with, that specific generic brand that they prefer. And usually that works fine. But in most cases, I really don't think there's an observable difference.
Dr. Tate, for me, Dave here, really appreciate your complete presentation. Very informative.
Oh, you're so welcome.
Okay, the next question I've got here is, can you talk a little bit about orthostatic hypertension?
Okay. So that's a common non-motor issue. I would say typically would happen in not necessarily early on in Parkinson's disease, but more moderate to advanced Parkinson's. So essentially what happens is that, the reflexes in our cardiovascular system that are supposed to regulate our heart rate and blood pressure when we change position, like when we stand and our blood kind of, drops and pools to our legs aren't working as well. And that's usually because of impairment of the autonomic nervous system, which, we know is impacted by Parkinson's. So the common way that it presents is, like I said, if somebody maybe stands, especially if they stand quickly or they sit up in bed, they might feel lightheaded or dizzy. And I mean, in extreme cases, they can faint, they can pass out. And so there are, multiple ways that we can manage that. I mean, for one thing, and I do want to emphasize, like, this is something that's triggered by Parkinson's itself, but some of the medications that we use for Parkinson's can exacerbate it. So we have to be aware of that. We have to look at a person's medication regimen and see if any of those, can, if there's leeway for adjustment in their Parkinson's meds. But then there are also other ways to manage it. Compression socks, like prescription strength compression socks, abdominal binders help. And then there are a variety of medications, oral medications that people can take that, if the problem is pretty severe. So, it is a manageable symptom. Usually we manage it kind of in concert with, either on our own, neurologists, we will, manage it, or sometimes we'll involve a vascular or specialist or cardiologist to help us manage it.
Okay, thank you.
Mm-hmm.
This is a two-part question, but it's on the same subject. What is the likelihood that Parkinson's is inherited?
So about 10%. I mean, if we look at all people living with Parkinson's, we believe so far that about 90% is what we call sporadic, meaning, I mean, there are genetic factors, but it's sort of this soup of sort of genetic risk factors and maybe environmental risk factors, maybe exposures that people have had to certain things throughout their life. So, in those cases, it's typically not passed down from one generation to the other. It just happens sporadically. In 10% of cases, it is genetic. So it's based off of a single gene that we can often test for. So that PD generation, initiative that Deanna mentioned at the beginning is one way that we can look to see if there, is a positive gene associated with Parkinson's.
Okay, thank you. You've answered part of the next part. How do we convince our neurologist or doctor to take seriously that as a family member, we're exhibiting some of the same symptoms as our loved ones are in PD?
I mean, that's a challenging one. I mean, like I said, I would always say if you just don't feel like you're getting that your question, a particular question or concern you have is getting the attention that you think is warranted, then, seek out another opinion if possible. But one way to know better, whether you might be at risk is, like I said, having your diagnosed family member with Parkinson's, maybe submit, a sample for the gene testing. And then, if that comes back positive for a particular gene, then, you kind of know that you need to push further.
Okay, thank you. Next question. Who is right for the neural patch, and does being out in the sun affect the amount of medication that is being delivered?
The Nupro patch.
Mm-hmm.
So, and the medications, I guess specific medication recommendations are always really challenging to make when I don't have the full background. But I can say that basically, the context I would usually prescribe the Nupro patch is when somebody is maybe beginning to have some of those medication fluctuations. So, their carbidopa, levodopa maybe isn't working optimally. They're having maybe some slight early wearing off or something like that in between doses. And we would use the Nupro as an add-on to, kind of accentuate the work of the levodopa. So, it can technically be prescribed just as a monotherapy, meaning it can be used on its own in milder Parkinson's, but it's more typically used as an add-on. So again, I mean, without probably knowing more details about, a person's specific medical history, it's hard to be more specific than that.
Okay, great. Thank you. Okay, next one. Could you please talk briefly about atypical Parkinson's And is the treatment different?
So that's a really good question. So generally, kind of making a broad generalization. So atypical Parkinsonism, there are several diseases within that group. So some of the common ones, progressive supranuclear palsy, or what we call PSP, multiple systems atrophy, what we call MSA, and there are two subtypes of that, Lewy body dementia, and corticobasal degeneration, or CBD. And so, like I said, making a broad generalization, those atypical Parkinsonisms, they do tend to kind of be more aggressive than Parkinson's. So they can progress more rapidly. Sort of some of the particular symptoms can be more severe than they would be in a person with Parkinson's disease. And in many cases, they don't respond as well to the medications that we use for Parkinson's. So that can make it a real challenge, for people that are experiencing atypical Parkinsonism, because we don't always have good medication options that work well. So we really rely on kind of our supportive care team, like physical therapy, occupational therapy, speech therapy, to help us with some of the symptom management.
Okay, good. Thank you. This one kind of hits close to home for me. Do PD patients have any special eye symptoms that we should see an eye doctor for? Any research with Wake Eye Center that you know of specific to Parkinson's?
Let's see. I don't know of a specific study that's ongoing. I mean, at least at Wake Forest Baptist Health, I'm not aware of a specific study that focuses on the eyes in Parkinson's. But yes, I mean, there are specific eye problems that arise in Parkinson's. I mean, one that sounds really straightforward but can be a big problem is dry eye, because often people don't blink as frequently and they don't moisturize, so that means that your eyes aren't as well moisturized as they should be. And that can create problems with vision. That can create blurred vision. And other issues, sometimes trouble with alignment of the eyes, when people are focusing in on things up close or at a distance. And sometimes, frank double vision that might relate to that issue with the alignment of the eyes. And, sometimes there are specific things that can be done to manage that, like prism glasses and things like that. But yes, you would need to, see an ophthalmologist. There are some specific neuro-ophthalmologists out there that are probably the most experienced with some of the things like this. We do have one at Wake. But yeah, certainly bringing those to the attention of your eye specialist is a good idea.
Great, thank you. Next question. What causes toe curling? I've heard from members of my support group that this symptom has started and or gotten worse during COVID. Could that be because people have been more isolated, stressed, and sedentary?
I mean, yes. I think being more sedentary, unfortunately, I do think that has a big impact on Parkinson's symptoms. It does aggravate Parkinson's symptoms, because we know that exercise is great for, kind of both reducing symptoms in the short term and just having people feeling better, but also we know it has long-term benefits at potentially slowing progression of motor symptoms. So not having that access to as much physical activity can really make things worse. Stress as well. But toe curling is usually a symptom, so we call it dystonia. And it just is basically involuntary, it is generated by the brain. It's not really the muscle's fault, but it's involuntary drawing or contraction of certain muscle groups in the body. And sometimes it's a medication related phenomenon. So sometimes that will be a lot more likely to happen when people wear off. But sometimes it's not. And so sometimes we have to use other management strategies like Botox injections. So Botox will help relax muscles that are overactive. So again, definitely something worth bringing up with your neurologist, because there are probably ways that it can be addressed.
Okay, final question. We really appreciate these answers. Thank you. I'm currently seeing a family doctor and need to get into to see a neurologist or specialist for changing symptoms, can I ask my family doctor to call the neurologist to give the person more information? How do you recommend I get my care team to communicate with each other if they're in different locations?
So that is a challenge. I mean, do keep in mind that sometimes even if the location, if it's a separate healthcare system, we do have access to a lot of records, not always everything, but through this thing called Care Everywhere, where we can kind of link in to another healthcare system's records for a particular patient.
Mhm.
And again, that's not always the case. It's not the case for every medical group. But we may be able to see each other's, information that way. When you ask your doctor for a referral, often it is difficult to reach other physicians in person, or it can be, but just try to be sure that your records, your paper records, are actually sent ahead of time. So that, that can be a tough thing when we have an appointment scheduled and then haven't received any of the records on the background for that particular patient. So even if it means you requesting them yourself so that you can carry them in with you to the visit, and you always have access to your own medical records. You just have to ask. Just make sure that the records arrive at the neurologist's office, if at all possible.
Great. Thank you so much. We really appreciate all this information.
You're so welcome.
You covered the waterfront. Thank you.
Thank you for having me.
Appreciate it. If we didn't get to the questions that you have in your mind and from the audience, we will try to get to them later, even though we can't do it right now. So we appreciate your time again and all the information in your background. Thank you, ma'am.
You're welcome. And yeah, I will try to be sure and take a look at all those questions later and try to respond to as many as I possibly can.
We really appreciate it. Now we're going to learn about benefits of telemedicine from Dr. Piboolnurak, who is a neurology specialist in movement disorders at the New Hanover Regional Medical Center in Wilmington, North Carolina.
Hi, this is Dr. Piboolnurak. Thank you for having me here for the talk. And as you can see, my last name is very long, so most of my patients call me Dr. P for short. I'm a movement disorder specialist at the Wilmington, and as you can see that we now become part of the Novant Health in Wilmington here. And today I will be giving a talk about telemedicines in Parkinson's disease. So what is the telemedicine? Telemedicine means that we can take care of you as the office visit, but outside of the office visit, at your home or anywhere or in your car. So it means that you don't have to be in the office, and we can still take care of you. With the technologies, we can now using the desktop computer, the laptop, the tablets, and the iPhone, or any cellular phone that has the ability to use the internet and camera. And that way, I will be able to talk to you. You can talk to me. We can examine you and do things, discussion while we are away from each other. And why we want to do the telemedicines? Before, actually, the telemedicine has been around for a long time. It's just that it's not become very popular until lately when we have the COVID pandemic. And that's become the time when the telemedicine become widely used. And so basically thinking about it, telemedicine is very good. You don't have to come to see the doctor. You don't need to wear a mask. You can see the face of your doctor, and then I can see your face. And it's very good for someone who has some problem with ambulations and the mobility. Some people even need the transportation and have to pay for the transportation to bring you to my office. So by using the telemedicines, then you can at home, you don't have to go anywhere, and they still can take care of you, and you can save the money. You don't have to pay for the transportation. and zero travel time. You don't have to worry about the traffic, and you can be very comfortable at home even when the doctors are late. And then usually I tend to be late often. And if I'm late and you're sitting in my office, then you may feel not that so comfortable. So if you're at home, you can do something. I can let you know that I'm late, and you can just go and have dinner and have snacks and watching TVs while waiting for me. And another thing is that family members from far away can join the meetings, because sometimes you may have the family members in the different states, but they're concerned about you. They cannot join you. They cannot travel to come to the visit with you. We can have that family members join in the telemedicines as well. And what doctors can do during this type of visit? Actually, we can do everything. History taking will be exactly the same as when you're in person, because I just talked to you, right? And examination, especially for Parkinson disease, is very, very easy, which I will show you how at the end of the second half of the session, on what I can do on the examination for Parkinson's. Cognitive function tests can also be done easily. And sometimes we still need your family member or your caregiver to be around a little bit, just so that we can check on other things. For example, the strength, then I cannot examine your strength. Or if you have a problem with walking and I want to see you walk, then definitely we need someone to be around you so that you will not fall. And another thing that I think is very, very useful, especially with the telemedicine, is the evaluation of response to levodopa. In the past, before we used the telemedicine, sometime when I asked my patients or family member and said, okay, you're not walking well, you feel stiff and frozen, and you cannot move around. And usually I ask, what time in relationship to the timing of the levodopa? Is that because of at the peak dose doesn't work well? Then I have to adjust the numbers of tablet per dose. Or if it's because of the wearing off, is when the levodopa wearing off a few hours later. Those are the informations that is very, very important to help us adjust the medications. And sometimes difficult to know because some family members, some patients may not know what to look for before this telemedicine time. I sometimes even have them come in and stay with me for half a day, and then I can see them between the visits, between other patients' visits, so that I can check on them, like for example, 30 minutes before, after taking levodopa dose, an hour taking levodopa dose, and then a few hours after taking levodopa dose. Then that way I will know that how you do at the peak of the actions, and when you get worse, how long the medicine lasts for. And that will be very important information for me to help you with the dose adjustment. And if you have any side effects, then we can see in person too. For example, when you have a dyskinesia, there are different types of dyskinesia. It can be at the peak dose dyskinesia, or when the medicine is wearing off and you have dyskinesia, then the treatment is completely different. So the telemedicines, we can use it to really check on you periodically without being in the hospital, in the office. So I can just say, okay, I'm gonna call you in again in 30 minutes or 40 minutes or an hour or something like that. Now, the ability for the doctor to be able to see you even though you're away. Let's say you want to you have some problem with Parkinson's or medication or something, and we don't know what to do. But by the way, you are on a vacation somewhere else outside the city, then or outside of the state. Then we can use the telemedicines to see you wherever you are. And I have another time that I have a patient who went for a vacation in Colorado, and then they got stuck there because of COVID. They cannot come back, and they had a problem with the medications and need adjustment. Going to be difficult to see new doctors in Colorado. So with the telemedicines, I can see you even though you're away from the city. And that is very, very useful. Now, I would like to tell you a little bit about the future, because right now it's just starting point of using the telemedicines. I have some dreams. I don't know that will become true, but this is what I'm thinking. Um, so in the future, if we can do using the telemedicines for multidisciplinary care. As you know, some big hospital have the multidisciplinary office visit where you go there and spend time with them for 6 hours, and then you're going to see a lot of different type of doctors and providers. Psychiatrist, social worker, PT, OT, neuropsychological testing, memory, and everything. So, but if we can use it telemedicines, then maybe you don't even have to spend those 4 to 6 hours. Maybe it will be a true patient-centered care if you will be in a visit and all those 3 or 4 doctors or providers or OT, PT, or social worker, depends on what your needs, to be at the same time. And then we can talk and discuss about your symptoms. What's your main concern? What is the tricky business about the medication adjustment? And we need a lot of experts to help to figure it out. That telemedicine will be able to help very well, because all of us can come in on the same visit, and then at the end of the visit in maybe 30 minutes or 1 hour, you already got everything ready to go. For example, let's give you some example. Someone with the Parkinson's with the orthostatic hypotension, which means the blood pressure drop when standing up. In that situation, maybe we can set up the office visit to the telemedicines, but with 3 doctors, like primary care physician, cardiologist, and neurologist at the same time. We can figure it out things together. Otherwise, currently what we have to do is that, oh, okay, you are taking the medicines for the blood pressure or the heart, but your blood pressure is low, but you need to take levodopa or dopamine agonist for the Parkinson's, which also can lower the blood pressure. So what we're gonna do? And if we're gonna try to reduce the medicine for the blood pressure or for the heart, that can be tricky, right? Because it can be important, and I cannot just decide by myself which one to reduce. Then usually what have to happen to that we have to do is that I have to send a message to the cardiologist, to the primary care physician, and then have them get back to you, and then kind of encircle and then try to figure it out on what the dose to be. And then I'm going to adjust the levodopa, the blood pressure is going to go down again, and then we have to go back to the primary care physician and cardiologist again. So if we can do the telemedicines at the same time, that will be perfect. And another example, Parkinson with dementia and hallucination and agitation. In this case, we can have a psychiatrist join in a visit, and we can plan together. As you know, that a lot of some types of the antipsychotics can worsen the Parkinson, and sometimes psychiatrist doesn't know about it. And if we can talk together and say, okay, in this situation, we have to avoid this and avoid that. But if we cannot avoid, what will be the first one that will be less side effects, and maybe keep the Haldol for the last resort, something like that. Then we can really come in and game plan much better in the same visit. But this is the future. I don't think that we can do it right now. I just talked to our a team in a business side team or insurance team. They said that they will not allow us, the insurance will not allow us to have more than one physician or providers on the same visit at the same time. So at least right now we cannot do it. But the future, hopefully, people in the insurance and government will see the importance of this situation, and can do that for the future. And actually, something like this can be even getting a second opinion. For example, we want to get a second opinion from Mayo Clinic, from Harvard, from somewhere, and maybe you don't have to travel there. And we can even have the visit together, and we have an expert in the field joining. That's another possibility too. Now, another thing is that this is I talk about it already, that we may even have the movement disorder specialists from far away from home, other counties, other states, or even other countries, right? We can get a very good collaborations work in order to help you get better. And not just a telemedicine. I'm thinking about the future technologies, the AI, or we call it artificial intelligence, that can help us to take care of you at home by monitoring your walking movement. You may hear about the wearable that can be a sensor to detect your tremor, the slowness, or can even predict the falls and prevent you from falling, or remind you to take the medicines. All these things is in the future, but I think anything good about COVID is that all these things can happen faster. Otherwise, if without a COVID, this thing gonna take even longer to happen. But this is a good aspect of COVID pandemic. And how to make the telemedicine more accessible, because as you know, a lot of people do not have the internet access, is not technical savvy, do not have device with a video camera. So we have some potential solutions here. That's what I'm thinking. Number one, we can do some partnership with the pharmacies, grocery stores, post office, libraries, and school senior centers or something, that they may have a booth for the with the laptop, tablet, with the video and internet access, and then you can use it there near your home and to help to get you into the telemedicines. And then in case if you are living in a remote region with weak internet signal, then mobile Wi-Fi hotspot can be used as well. So that's what I'm thinking, that telemedicines can be more widely used. And this is my last slide. And after this, I would like to show you on how the telemedicine's office visit will look like. And we had a pleasure to have Ken joining us later, right after this, to show you how we do the telemedicine. Thank you for your attentions, and hopefully in the future I will be able to see you in person after the COVID pandemic recover. Thank you. Hi Ken, how are you?
Hey, how are you doing?
Very good, and thanks again for helping us today to demonstrate on what usually we do for the telemedicines.
Oh, you're welcome. Very welcome. Can
Thank
you
you.
see me?
Yes, I can see you very well. I can see you very well. So first, we're gonna make it like similar to what you usually go to the doctor's office. So I'm gonna ask you, okay, so can you tell me how can I help you today? What is your concern? Are you taking medicines and is it working well, or any problem?
Well, I've taken the standard medicine for, carbidopa, levodopa. And right now on the 25 100, I take 2 pills at a time, spread throughout the day, a total of 10 pills. And then at nighttime, I take the 50 200, the ER one.
Yeah.
And just one of those.
Okay.
And,
okay. So when it works, does it work very well at the peak of actions?
It works pretty good. I guess my probably the mornings are the most where I feel it maybe not kicking in, and that's
right.
maybe after going to bed and then taking the one, and then takes a little bit of time.
Right.
So I notice a little bit more tremors and unbalance in the mornings.
Okay.
Once it starts, and then almost. I don't even have to time it too well, although I try to put it at the even hours, but my body is almost telling me, because I can see it kind of wearing off.
Right.
Or you're just shaking a little bit more.
Right. So usually after taking the levodopa, how long does it take to make it work? 30 minutes, 45 minutes?
Yeah, about that. Uh-huh.
Okay. And then how long did it last? Usually 4 hours, 5 hours?
I guess depending on the day, usually about 3.5, 4 hours, somewhere
Okay.
about there. And I
Okay.
can body almost can tell me that it's time.
Right, right. So that's good. It sound like everything doing well. And so if you don't have any other question or concern, just want to do some examination just to make sure you're doing pretty well.
Okay, all right, sure.
All right. So first, I would like to know how long ago after you taking carbidopa levodopa before this visit?
Before this visit, it should be 12 o'clock I took it.
Okay, so it's about 2.5 hours.
About 2.5 hours.
Okay. Usually I like to ask this question so that I know what is in your cycle when I examine you. So they say, okay, whatever I see you now is at the time when the levodopa is in your system.
Okay.
So what first I want to do is just sit and relax and put your hands on your laps and relax like that.
All right.
Yeah. Palms up. Palms up. Yeah. And close your eyes. Close your eyes and count backwards from 10 to 0.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Okay. Now open your eyes. Now hold your arms up in front of you. Now touch your nose and then touch your finger, going back and forth.
Okay.
And touch your own finger. Yep. Like a one. One hand still, and then move just another hand.
I got it.
Yeah. Yeah. Okay. And then switch to another side. We'll do
Okay.
it a different way. Yep. Okay. All right. That's good. Now we can relax now. And could you tap your finger, right hand first?
Right hand first.
Yeah,
Yes.
right hand.
Do pretty good with this.
Yeah. Just these 2 fingers, like that.
Oh, okay.
And then the left hand. Okay, and the right hand open and close. Okay, the left hand open and close. Okay, and the right hand turning. And the left hand turning. Okay, now the right foot tapping.
Okay, can you see my feet? I'll move back a little bit. Hey, when
Okay,
you
now tap your foot. Again, the left foot this time. The left foot. Okay, now tap your foot this way. The heels on the floor and tap the foot. Just one foot at a time. Right foot. Tap, tap. And then the left foot. Okay, it seems like you have a little bit slower on the left side of your body. Must be the first symptoms start out in the left side, right? Your Parkinson's?
Actually, I more started in the right, but
Okay. So today it seems a little bit slower on the left.
it's probably just because I'm normally uncoordinated before
Okay. Now, fold your arms and stand up.
Okay, yeah, that I can do.
Stand up. Okay. Now you can put your arms down and then just walk around, turn around, and walk to the door. And we'll need your family to help as well, so that you're not falling. You put your arms down, relax.
Oh, okay.
And then I want you to walk, turn around and walk back to the door.
Okay, tell me when you can't see
Yeah,
me.
yeah, I can see you pretty well. Very good. That's very good. Okay, now turn around. Okay, and then come back. Okay, now you can sit the same place again. And I'm gonna need your family to help with the checking the strengths a little bit too.
Okay, and this is my wife, Diane.
Oh, hi, Diane. Thank you so much for your help. Okay, now I'm gonna want to check your strengths. Hold your arm this way.
Oh, like this.
Okay, yeah, and then your wife, Diane, can you push his arms down like that and see if he's strong? Pretty good? Okay, then let's do another side. That's good? Okay. Now close your hands tight like that. Squeeze your hands tight.
Oh, me?
Okay. Now, Diane, could you try to open his finger to see if he's strong grip?
Oh, his finger, push it away or?
Yeah, try to open his, try to open his fingers. No, right? Okay, good. The left hands. So it's strong, right? He's pretty strong there. Okay. Now, could you lift up your legs like this, and then Diane will try to push it down.
Okay.
Lift it up. Yeah, and strong. It's good. And then another one. Another one. Okay. Now that's good. All right. Now, Now I want to just checking your face movement a little bit. Can you smile? Smile. That's good. Open your mouth. Stick out your tongue. Okay. Now now look straight, and then now move your eyes to the right. Move your eyes to the right. Keep your eye, move your eyes to the right. Maybe yes. Maybe Diane maybe can help you us a little bit. Could you bring your finger in front of him, and then have him? I want to see if he can move the eyes properly. Okay, that's good. Now to the right. Okay, and then straight, and then look up and down. Okay, so your eyes moving good. And actually, just for the sake of time, otherwise we're gonna have you move your face closer to camera, but we don't have to do that. And then we can see the eyes even better.
Well, first of all, again, thank you guys both so much for your time today. Your presentation was very informative, and I loved seeing the telemedicine appointment. I think it's helpful to see that, and how it would actually work. So just a few follow-up questions for you, Dr. Piboolnurak. As far as scheduling a telemedicine appointment, do you require, I know your practice, and I know in other states it might be different, but do you require that a patient sees you first in person before they see you via telemedicine?
Actually, for me, I'm pretty flexible. Given the COVID pandemic time, I'm very flexible, and I know that sometimes difficult to come because sometimes they are in a nursing home, they're not allow anything. So actually, I have a few patients that I see first time in the telemedicine, because sometimes we can evaluate what we can do, and then maybe enough information to do anything. And then if we don't feel like we have enough information, then we can have them come back and to see in person. So it's not like a fixed rule that we have to do this first or that first. Depends on situation.
That's great. That's
sometimes I have a patient who came first as a new visit in person, and then I just want to checking on what happened with the dose adjustment. It's like a quick adjustment thing to do, and don't have to coming all the way here. Then I do it on the Zoom.
Well, that's so convenient, because I know people, and Ken, you can probably, attest to this, that it can take all day, even if you just have a follow-up appointment scheduled to check, if you're taking the proper dosage or right medication. That can take all day. So it's nice that now people can just check in with you quickly.
Yeah.
15 or 20 minutes. That's really from the
right. And we can see exactly what happened, because otherwise, if you call us and say that, okay, I still shake, then they can be shaking like a tremor, or shaking like dyskinesia shaking.
Right. Yeah, absolutely.
And we can see exactly what you mean.
Mm-hmm. No, I think it's great, because just the travel time, to sometimes see a doctor, can, like I said, all day,
Yeah.
Get in your car, drive an hour.
Right. So I think it's all the benefit. We should do more in the future, even after this COVID gone.
Oh yeah, I agree. I think this has opened up so many pathways and doors.
That's right.
Tremendous.
Well, and knowing that you're, Dr. Piboolnurak, you're in this region, and you're a movement disorder specialist, so you're truly an expert, when it comes to Parkinson's. So really, it's good news that anybody, regardless of where you live, really now has access to an expert, and that's exciting. I guess on the flip side, are there ever situations with Parkinson's where you feel like telemedicine would not be ideal? Anything that you can think of where someone would actually need to come in and see you in person rather than via telemedicine?
Actually, the Parkinson component is the easy part. It's a telemedicine part. It's not a problem at all. Usually it's something else. For example, if it turned out that something new happened, weakness on one side, like let's say I ask you to lift up the arm, you cannot even lift it up the arms, and I ask your wife to check on the strength, and then it's weak. It's maybe a stroke, maybe something else completely. Those are the things that we need to be in person if it's not just a Parkinson, but something else going on, or if there's something that I need to check the sensations or something like that, or reflex, or the balance, like I have to do the pull test, but I cannot ask your wife to pull you in front of me and then you can fall and that will be difficult. Actually, for sensations exam, sometimes can be easy too. One time I asked their family member to use a toothpick, get a toothpick or a paper clip, and then poke on the feet. I said, okay, poke here, and tell me how you feel. We can do a lot of things. And I noticed that there's a stethoscope that designed for the telemedicine. And also ophthalmoscope that designed for telemedicine.
And
So I think all these things will
coming
come
out
up and you can use
yeah.
all these tools. And actually, that's another thing too. Let's say someone like a remote, like a very far away to come to his doctors and want to do telemedicines, but then it's going to be difficult to in terms of examinations. We can even have someone, like a nurse or something in the PCP's office to help the patients on during the visit to the examination part and can report to me. And I tell what I want to know.
That's great. So somebody could actually go down the road in theory to their, a primary care physician's office, and you could, in assistance with a nurse practitioner, somebody else on staff could actually facilitate the same.
Right, a nurse, medical assistant, or someone. But the problem is about the insurance, as I mentioned earlier, because I talked to someone before, because here we try to kind of form the team to be like multidisciplinary things that I share, visit. But it turned out that the insurance will not allow us to bill for those type of the visits. So basically, when you do something like that, only one can billing, but that's not gonna survive. But maybe we don't need a medical doctor. Maybe we don't need the APP. Maybe we just need a medical assistant or RN or someone that we train for this.
Absolutely. Well, and Ken, from your perspective, I know you've done several telemedicine appointments in addition to our mock appointment today, but how have you felt about those appointments? And do you feel like you get just as much out of a telemedicine visit as you did going in person?
Well, I think you get very much the same in terms of the telemedicine. What's missing is, the doctors, giving a doctor
a touch.
Talking, right there in the same room. And so that part I definitely miss, and I think it's very important. But in terms of just what we just did, I think it works perfect. It's just a matter of do you have it's always good to, I think, to do it like a pre-test of your computer, or what I'm using, iPad, to see if it works. And then I know up at UNC, they you have to have a login and a password, and so depending on the type of the electronic media that you're using, Zoom or how
Yeah, I can see that sometimes it's difficult for that, and we try to make it to be like a link, like what you invite us today, like just click only.
Yeah.
And then it just lock in automatically. You don't have to type anything, just click and get in.
Yeah. And Dr. P, do you think, always before I see the actual movement, my doctor would be, take your weight, take your blood pressure. Could that be something like, with the wristbands?
Yeah, actually, our office here, I always tell my medical assistant that if it's a telemedicine, and ask them if they have the blood pressure cuff, so that they can check it sitting and standing, because a lot of people don't sit checking and standing, and then orthostatic hypotension can be missed. So usually I ask them if they can do it. They do it beforehand. And then when they check in, talking about the medication and everything, they ask for that information.
I'm gonna go next time up to the pharmacy and get one of those.
And nowadays there's many style, and you don't need a fancy one.
Right.
Actually, the wrist one is good enough. And just ask the pharmacy which one is reliable. That's only the thing. And you can check sitting and standing.
That's good.
And the price point is very, very, very good too. It can be just $20, $30. Sometime when we meet in person, I like to show the pictures, MRI, and or if someone asking about some certain technique, and I like to use the internet and research it and look at it, explaining it. Then I can even use the share screen version. For example, this is from Google. It has not become any a real patient, so I just want to share and then show to you. So something like this, and let's say I share that. Then let's see, and then you see the MRI pictures. I can show what it looked like, or if someone asking about the certain type of the scan, what it looked like, I can type it in and show it. Or if something I want to show about the ustep.com, which we use for the walking problem with the freezing, I can do that. And I can even show the video on the walker that can help with the Parkinson walk. So we can do all this on the telemedicine, exactly the same as what I usually do. And then I stop the share. Just want to show you that I can show the MRI pictures. I can show your scan result pictures like that.
Amazing.
That's great. It's almost like you could get even more out of a telemedicine appointment than you would sitting in an office or sitting in a car.
And it's more
trying to get to
comfortable,
the
right?
office.
We at the home.
Yeah.
You can sit and relax, and you don't have to wear a mask.
Exactly. Well, and if you don't have access to the technology, I know that came up earlier. If you don't have Wi-Fi, if you don't have a device, would mainly your recommendation be to again find a friend or a neighbor or somebody who could assist you with the appointment? I'm sure there are so many people who would be willing to do that. It's just a matter of you setting up the appointment and then finding the technology. I was going to say, we've got a great Parkinson's Foundation helpline as well, 1-800-4PD-INFO. And I know that it's staffed by nurses and social workers, so that if you are struggling with telemedicine or finding a provider or figuring out technology, I know that they would be more than happy to help with that. So, well, thank you both so much for your time today. This has been really wonderful. Dr. P, Ken, thank you both. And I hope you both have a wonderful rest of your day. So thank you.
All right. Thank you. Okay. Thank you for having me here and be part of the this talk.
Thank you very much.
Bye, everybody.
Hi, well, thank you so much, Dr. Piboolnurak and Kent, for a fantastic presentation on telemedicine. Eastern North Carolina region needs more people like you to help us, so thank you so much. My name is Dr. Jennifer Hodson, and I am a professor and director of the Medical Family Therapy Doctoral Program here at East Carolina University. I'm in the Department of Human Development and Family Science in the College of Health and Human Performance. I've been involved at the Eastern North Carolina Parkinson's Support Group since the early 2000s. And for the next 5 minutes, I'd really like to take those of you who want to stay through a little mindfulness exercise. We have found through a lot of research that just simple things like slowing our breathing a little bit helps us to better control stress, helps our body to heal, helps us to sleep better. It slows our respiration and our heart rate, which when anxiety goes up, we say options go down. So we really want, if we're going to be faced with a situation where we have clear mind and clear heart, doing something like diaphragmatic breathing can really help people to get to that place. Sometimes we need diaphragmatic breathing before we go into a telemedicine visit. So what I'm going to ask those of you who are with us still is to, if you're seated, that's fine. If you want to stand, that's fine too. And sometimes I even teach people this when they're laying down, if that feels most comfortable for them. But I want you to take one hand, doesn't matter which, and put it over your chest, and the other hand and put it on your stomach, right? With diaphragmatic breathing, or we can call it 4 by 4 by 4 by 4, you're going to breathe in through your nose and out through your mouth. You're going to breathe in slowly to the count of 4. And while you're breathing in, I want you to concentrate on filling your belly with air, like your belly's a balloon. What we want to do is get a full range of lung use. And so by focusing on the belly, we're able to really expand those lungs so we can get a nice big full breath. So one hand on your chest, the other on your stomach. And then I want you to breathe in through your nose to the count of 4. 1, 2, filling that belly. 3, 4. Then I want you to hold for the count of 4. 1, 2, 3, 4. Now blow out slowly through your mouth to the count of 4. 1, 2, 3, 4. Hold. 2, 3, 4. Breathe in through your nose. 1, 2, 3, 4. Hold. 1, 2, 3, 4. Breathe out through your mouth. 1, 2, 3, 4. And hold. 1, 2, 3, 4. One more cycle. Breathe in through your nose. 1, 2, 3, 4. Hold. 1, 2, 3, 4. Breathe out through your mouth. 1, 2, 3, and 4. So these are really helpful breathing techniques to do before we make any transitions, to do an activity, to go to bed, to make a telephone call. Sometimes it's just really helpful to get ourselves centered and calm. So I hope you found that useful. The only thing I'll add sometimes is I ask people to visualize breathing in their favorite color and breathing out their least favorite color. So if you're a visual person, just taking in that beautiful calming color and imagine it going throughout your body, and breathing out your least favorite color and having yourself imagine it leaving your body until you're breathing in your favorite color and out. And that's when you know you can stop the exercise. So a couple of little brief mindfulness strategies for you today. We want to make sure that we get on to the rest of our presentation. So it's my pleasure to introduce our next speaker, Dr. Mark Stacy, who serves as the Dean of the Brody School of Medicine and Senior Associate Vice Chancellor for Medical Affairs for East Carolina University. Dr. Stacy is also a movement disorders trained neurologist, and he is here with us today. And Dr. Stacy, we are so excited to have you. So welcome.
Well, thank you for the invitation. I'm glad to be virtually with you all today. And I've been given an interesting task to describe what I think the future of Parkinson's care will look like. For a moment, I'd like to go and describe what the past Parkinson's care looked like. And so in 1988, the Movement Disorders Society was founded. The first international meeting was held in Washington, D.C. in 1990. At that time, we had 3 to 4 medications for Parkinson's disease: levodopa, we had pergolide, bromocriptine, and amantadine. We also had a meeting. In that first meeting, we only had 300 people. And we've exploded in terms of what we now do in Parkinson's care in the last 30 years. So we went from 3 drugs to probably 40. My career was built on doing research protocols, and I helped with the approval of selegiline, tolcapone, entacapone, pramipexole, ropinirole, rotigotine, apomorphine, proamidine, Nuplazid, and many other medications that didn't make it. with that evolution of clinical trial work, there became an economy for Parkinson's centers to evolve, because we could get grants from pharma and from the NIH to do these tests and test these drugs. So that led to the growth of the movement disorder specialist. And when I looked for my movement disorders fellowship, there were probably only 4 in the country. Most departments of neurology would like to have 1 to 2 Parkinson's disease specialists. Today, when we look at the Parkinson's disease community, there are probably 2 to 5 centers in every state, and every neurology department would have some movement disorder specialty. And there are movement disorder specialties throughout the country in private practices. It is not difficult to find a movement disorder specialist in this country, but it is still a little bit of work to drive there and see people. I'll also point out that in 1990, we had the APDA, the National Parkinson Foundation, the Parkinson's Disease Foundation, and the Parkinson's Institute. And today we have many, many other organizations. The Parkinson's Foundation, it was combined through the National Parkinson Foundation, the PDF, and the Parkinson's Institute. The APDA remains. We have the Michael J. Fox Foundation. We have the Davis Finney Foundation, a whole range of groups that can provide information and assistance in their area of expertise. And we have the growing fellowship programs in which you can seek care and have a chance to participate in a clinical trial, have a chance to have surgical treatment for Parkinson's disease, have physical therapy, occupational therapy, speech therapy, nutrition therapy, all kinds of things in an initial visit or in visits as you come to centers. So I enjoyed my Parkinson's disease clinical life immensely. It was one that grew in the size of my centers. It grew in the size of patient populations. It grew in the geography of patient populations, and it grew in the range of therapies that we offered. And then the pandemic hit. And so in this pandemic, we've learned a great deal of things about how we deliver care and who we deliver that care to. And it's a very humbling experience. We first had to assess and find ways to keep people safe. And then we had to think about how we could deliver vaccine. So in Eastern North Carolina, there is a tremendous poverty in some places, and there is a tremendous health disparity. And so one of the things that we did with an initial grant for vaccine delivery was to look at the ethics of vaccine delivery. So we wanted to be able to deliver vaccines if we were not able to get enough for everybody, to the population that would provide us the most immunity. So we started looking at population health, and we would be able to say, let's look into a home with a 65-year-old man who has a history of hypertension, high blood pressure, and asthma. And he lives in a multi-generational home. So he's a grandfather, has children and grandchildren in the home. He is at most risk for getting COVID, but he may be too ill for those COVID vaccines. So when we first started to give those vaccines, we were worried that people would have adverse reactions. We now know that that's not very often, but still we know there are adverse reactions. And if he had a history of blood clotting, maybe we would not have wanted to give him a vaccine. And what we would have wanted to do was vaccinate the people around him. And that way we would provide him some safety, because people would not be bringing COVID into the home, are not as likely to do that. The next thing we've done in our work with vaccine delivery is we are now going out to see people. and see people that are in group homes. Then we also have started seeing people in small companies. So we went to a local company several months ago, and it was a company of about 20 people. They all had insurance, the deal was you get a chance to get vaccinated if you come to see these doctors. We started asking people questions, and we asked them questions about what their barriers were to care. And we found out that the number one barrier was it's too complicated. The second barrier is it's scary. The third barrier, it takes too much time. And the fourth barrier, it's too expensive. So in the course of one of these visits, a woman came in and answered these questions, and we did a brief exam and discovered that she had a diastolic blood pressure of 145. That's the bottom number. It actually is the highest blood pressure I've ever seen in somebody that is not in an ICU. And the doctor asked if she knew she had high blood pressure. She did, and asked her if she'd ever been on medications. And she had been on medications, but she quit going to the doctor and couldn't get another refill. So when she was asked if she didn't like the doctor, she said, "No, I like the doctor. It's just I have to take a day off work. And when I get there, the doctor finds all of these other things he wants to evaluate. And so then I get tested, and I don't have time for all of that. I don't want that evaluated. I know I should get my blood pressure tested, but that's all I need." So we agreed to start a blood pressure medicine, and she agreed that she would see us one time in a telemedicine visit. And so we saw her in a telemedicine visit. She could take her own blood pressure at home, and we saw that her blood pressure had improved. And then we set up a future array of care through telemedicine visits to take care of what she wanted, not what me as a physician would find. And so I liken this as to something very much like an emergency care visit. When you go to the emergency room, you really know why you're going, and you want that taken care of, not necessarily other things. And so we learned that in the pandemic world, that in reality, as a physician for my whole career, I really only took care of people who had the resources to see me, who could take the day off work, who had the insurance, and who could manage the very complicated visits. Because in my last job, if you came to see me, I had OT, occupational therapy, physical therapy, speech therapy, counseling, and nutrition therapy on site. And we actually had a system of visits that if you wanted to come for a half a day, you could see all of those people. We were always surprised that nobody wanted to do that. Now I know why. It's just too complicated and too scary. So this population health modeling that we did to look for people at risk for high blood pressure and are risk for vaccine reaction is now something that we're doing all the time. And we can go into neighborhoods and households and through electronic medical record charting in an anonymous setting, so we're not having any HIPAA violations, we can determine the burden of disease by zip code. And so one of the things that I think is going to change in medical care is we're going to get really good at population health, and we're going to use public health to inform physicians about care in their area. And so we're going to develop an algorithm in which we can tell Dr. Smith in Edgecombe County, your county health risks are boom, boom, boom. Here are the 7 things. And provide a list of questions. So those questions can reflect the disease burden in the area. And then we want to see if we improve that disease burden in the area. So before Brody School of Medicine or ECU School of Medicine had a multi-specialty practice in 1990, people in Eastern North Carolina on average died 2 years younger than everybody else in the state. When we looked at data in 2017, we found that we normalized that. So if you look at even the location of a medical school and an increasing healthcare system, over the course of 17 years, we gave 1.7 million people 2 more years of life. That's an astounding success. And I think it reflects the last 30 years of how we have improved care. But in our world of health disparities, we now know we are not reaching people who really need our help. And we're not reaching them because it's too scary, it's too complicated, and it takes too much time. It also is too expensive. And we're going to have to move into a public health world in which we can prevent disease because we can't afford to treat it. So my vision for the future is I want to dismantle this apparatus that we built at specific centers, and I want to be able to put the apparatus at your desktop. And as you saw in the telemedicine visit in the previous session, that is not impossible to do. We now have insurers who understand that this is a very efficient way and a much less expensive way to deliver care. And we need to take those, we need to reimburse people for those visits in that fashion. So I don't have to bring you into my clinic and do a certain number of things so you qualify for a level 4 coding visit so I can get paid. I think that an investment in infrastructure is going to be necessary. We need to have high speed internet ability in every household in the country. But I think that we will be able to then reach out to people where they live to say, how can we help you with your problems? The other commitment that we need to make is we need to stop practicing at a full range of our license. As a physician, you want me to practice at the top of my license. You don't need me for many other things in care. And in fact, I'm not the expert. If you have a problem with weight loss, you really want to see the nutritionist. If you have a problem with speech, you need to see the speech therapist. And if you have problems with walking or with feeding and combing your hair and things like that, you need to see a physical therapist and occupational therapist. What you need to see a neurologist for is medication adjustment and determination if you qualify for deep brain stimulation or a clinical trial after medications alone are not working. So for me to practice at the top of my license, you as a patient have to allow me to do that, and you have to accept that yes, there are probably other people on the team that are better suited for my long-term care or this aspect of my care. So it's my hope that we can begin to build an internet structure that changes the way health is delivered, and it changes the way we access health in communities and in homes. And we now, thanks to COVID, have the ability to see that this can happen. And now we just need to implement it. So it's my hope that 30 years from now, we've cured Parkinson's disease. But I've been saying that for 30 years. But if we haven't cured Parkinson's disease, it is my hope that we will be able to find ways for you to receive care conveniently on your own time, in your own homes, and frankly, that we pay for it through a national service. So I think I've got us back on time a little bit, but those were the remarks that I prepared, and I look forward to answering questions because that's always more fun. So thank you.
Well, thank you so much, Dr. Stacy. Now we're going to take some questions from our web audience. Are you ready?
I'm ready.
All right. So question number 1, does ECU currently have any plans to establish a neurology department?
So we have hired a chief of neurology that will be in the division. It'll be a division of neurology and medicine. The chief of neurology is arriving in August. He has experience in building departments in 2 other locations, one at Georgetown, one at Ohio State. We want him to spend the third half of his career building out to a neurology department. We have neurologists that are on site, and he is going to coalesce them into a department, and we hope to start a neurology residency program within 3 to 4 years.
That is absolutely the greatest news I've heard. That's wonderful. Thank you so much. What is presently happening at ECU to raise awareness of Parkinson's disease among students in the medical school?
So I give one lecture a year, and I give it to the first year students and talk about Parkinson's disease and other movement disorders. We also have, for students that are interested in neurology, they find my door, and we have increasing numbers of students who are planning to move into a neurology career. But the curriculum is a very busy thing, and while I did most of my career just in Parkinson's disease, these medical students have to learn a lot of things for them to be able to go out and practice.
Okay, well, that sounds like we're at least exposing them to the content of the information. And do you get requests from some of the other programs in the university, nursing, physician's assistant, nurse practitioners? Have they also been utilizing your skill set?
So I do give a lecture in the physical therapy program, and used to bring some patients with Parkinson's disease for them to visit with. And in those days, it's expanded to where occupational therapy and other people in allied health visit. I look forward to a time when we can all be in the same room again and begin to explore that further.
I think that sounds fantastic. Count me in. So, all right, question 3. What is being done to address the need for specialists in the region? Recruitment, training, broader access to telemedicine.
So telemedicine can be done from anywhere. So we are looking at ways that we can, branding is not the right thing, but make that an ECU experience, because there will be times when you need to see a physician live and in person, or a health system live and in person. So we're working to expand our telemedicine from our telepsychiatry program. We have a program called NC Steps, which is a telepsychiatry program that really services emergency departments. And so if you have a patient that comes in who is ill with a psychiatric problem, we're able to use telemedicine and evaluate whether that patient needs to be admitted or the patient can go home. And it saves a huge it saves a huge amount of money and burden. Imagine if you came in to an emergency room depressed, and as an emergency physician, I would want to err for your safety. And so if I asked you to be admitted to the hospital and you said no, I would have an option of having you committed to a hospital. That's a big responsibility. And if you did not need to be committed to that hospital, it's a horrible mistake, and one that is very difficult for you to recover from. And you have depression anyway. So NC Steps has really done well in that. And we're beginning to use that NC Steps platform to expand to other needs. We've received a grant to look at maternal fetal health and at-risk mothers in several rural counties. And so we use this telepsych platform, but we are now doing maternal fetal medicine visits virtually. Who'd have thought you could do that? In that grant, we provide future mothers with nutrition evaluation, with food if they have food scarcity, with counseling if they need that, and then their maternal fetal care. So we are trying to build on this platform.
And what about the recruitment of specialists in Parkinson's to this Eastern North Carolina side of our state? Are you aware of any work that's being done in that area?
So when the medical school was formed, it was formed our mission is to educate doctors with an emphasis in primary care. And so we stuck a little too tightly to that vision for way too long, in my opinion. And so now we are a regional hub for health, and we need to offer a complete range of services. So it has taken a a little while to talk with the legislature to say, this is how we're expanding and this is why. And we found the right message for that. And the message is, we are educating primary care physicians that are going to go into your communities. You need to have that. They need to know a wide range of medical care, and they need to know it from specialists. And the best example we have was during a hurricane, I think in 2017, there was a physician in Beaufort County who, or in Beulaville, I'm sorry, who with his wife run a clinic. She's a nurse on the high ground in Beulaville. So, you know, about that much higher. And in the middle of a hurricane, a man came in suffering a heart attack, and a woman came in with delivering a baby who was in the breech position.
Oh, wow.
There would have been 60 people around those two issues if they were in our hospital. But a man and a woman took care of all three of those patients. And they all did fine. They all were helicoptered out, and they all have stories to tell for the rest of their lives. But that's the physician and that's the medical care team that we educate on this campus. We have to be able to do it all. And to do it all, we need to learn from specialty service. So I found the right message, and now we are trying to recruit in deeper specialties.
Well, that's amazing. And that's a great segue into the next question. Can you remind us what types of Parkinson's specialists are available at ECU?
So right now, there are no Parkinson's specialists available. When I arrived, one of my fellows, Dr. Ian Lee, was here. And he wanted to go back to Durham. And that was unfortunate because I was going to let him be my backup because I do miss seeing people. But I get called away a lot. And if you drove from anywhere to come see me and arrived and I had to be someplace else, it is not the way to deliver care. And so I plan to dust off my shingle when we have neurology here to back me up when I'm away.
Well, in your opinion, how difficult is it to recruit movement disorder specialists, and what needs to be in place at a medical institution to make that happen?
So I don't think it's difficult to recruit movement disorder specialists, particularly now. Living in Greenville, North Carolina is a whole lot less likely to get COVID than living in New York City. But you have to have a platform for them to live in. And as a Parkinson's doctor, I like to take care of people with Parkinson's disease. I read about it, I learned about it, I thought about it. I didn't take care of people with stroke. And so right now we have to concentrate on stroke. We have 3 neurologists that are experts in stroke that are on site. And so with the addition of a leader, we can begin to expand to these outpatient specialty practices. And I want to do movement disorders work. I don't want to do other non-movement disorders work. And so that's the barrier. Okay.
Well, hopefully as you build this, we'll be able to recruit those individuals and really grow this for the region. All right, another question that came in, can you please discuss any projects or ideas you may have related to educating primary care providers and other providers on Parkinson's?
So I think they have to be motivated, and you have to provide the motivation. As a patient-physician interaction, as you establish a stronger patient-physician interaction, you will be able to have conversations about medicines that you ever see advertised on TV, other treatment options. I think you have an obligation to say, you know, I heard this lecture and they talked about medicine kicking in 30 minutes and this thing called dyskinesias at 2.5 hours and then wearing off. What do those things mean? Do I have that? And I think that will allow a general physician to say, okay, I have to look that up. One of the things that I was going to say about the virtual office visit is when you have an office visit with your physician, you don't want to look good. If you have no Parkinson's symptoms, I think I've done my job and I'm not going to change anything. You want people, you want your physician to see your tremor. You want to see the physician to see your symptoms. And then you want to say, these are when I have the symptoms. I have them early in the morning. After my medicine kicks in, I do okay, but then my medicine must wear off because I don't do well at noon. And then I take another pill at 1 o'clock and I'm better for a little bit in the afternoon, but in the evenings, I'm really slow. And that's how you're going to be able to educate your physicians. And I've never met a physician who once he or she understood the rhythm of Parkinson's disease did not enjoy taking care of people. I would tell my residents, you can go in, or in students, you can go take care of people with hypertension and you know you're helping them. They may not know you're helping them and they may have side effects from that medicines and they may think, well, man, this is not doing me good. But if you take care of somebody with Parkinson's disease who has trouble walking and they walk better, they know you're helping them and you know you're helping them. And that's what I really liked about the Parkinson's disease therapeutic relationship. We were partners. You had to give me the information, even if I had to tease it out of you. And together we could work to maximize your mobility at first and then minimize other symptoms as they came around.
Right. And it sounds like collaborations between, teaching them to collaborate, the primary care providers with movement disorder specialists, even if it's not in your area, so that you can provide the best patient-centered care possible. So really building those interdisciplinary teams and teaching collaboration across institutions. Question number 7, are there things that people with Parkinson's and their care partners should be doing in this region to optimize treatment and ensure the best possible quality of life?
So you have to do what you like to do to ensure the best quality of life. I think you have to do things that allow you to work with your stress. Stress will greatly increase your Parkinson's symptoms. And so breathing exercises and mindfulness is very helpful with that. Happiness should always be a choice. Sometimes it's a more difficult choice than others. And frankly, the last year has been it's been more difficult to choose happy than for everybody. But I think that those are some of the things that you can do to help your own life. I think you have to look at, do you have a crash after meals? Sometimes you can eat a big meal and it will drop your blood pressure. And so you feel lightheaded or you just lose your energy. So smaller meals more often work in that case. Parkinson's disease is a disease of low blood pressure, in my opinion. And so if you just don't have any energy, check your blood pressure. Your blood pressure needs to be above 100 when you stand up, or you will not stand up long. And so increasing your fluid intake, reducing coffee and alcoholic beverages that can be a diuretic are important for you. A little salt on your food will raise your blood pressure. And so if your blood pressure is 90/60 when you're sitting down, a little salt will help that.
Wonderful. And I would also make a plug for support groups. Just get people connected to support groups. And sometimes it's the family member who will come and not the patient, sometimes patient, not the family member. And you're right, COVID unfortunately has brought with us lots of challenges, but one of the benefits is the virtual pieces that we're able to now do to support family members who are at a distance. So
let me add a little bit about support groups.
Right.
They can be a trap for you. At times there are people who should be seeing a therapist, but the support group is their therapist. And it's important for you to be able to pivot that conversation, because it's not good for anybody to hear somebody cry for an hour. And sometimes Parkinson's disease is something that you cry for an hour around. So you have to protect yourself and your own resilience in these settings. And I think you've got to find the right group that you gel with. Just because you have Parkinson's disease doesn't mean everybody with Parkinson's disease is now your friend and you're the same. So if you're in a support group setting that is not supporting you, you need to find another support group setting or talk through with the leader of that group to say, can we try other different things? Have courage with that support group and shape it to help everybody.
Well, we have some fabulous support group leaders on this planning committee, and I am so proud of the positivity and the helpfulness of our Eastern North Carolina Parkinson's support group family. So I think, Dr. Stacy, you'd be very proud to see these groups are very healthy and thriving. Yeah, they're wonderful resources. All right, final question. Do you have any plans to see patients again in the future? I know you said it earlier, but I think people want to hear it again.
So I do have plans to see patients in the future. I don't think that will happen until we begin to have a stable neurology presence. And so I don't think that will be in 2021.
Well, I think people here are super excited to hear that you might be leaning in that direction. All that expertise and training that you bring with you to our region means everything. So thank you again, Dr. Stacy, for being here today, for shedding light on expert care in Eastern North Carolina. We're going to switch gears and welcome our People with Parkinson's panelists to share more about their experiences building a support system and what they've found most helpful while navigating Parkinson's. Thank you again.
Bye-bye.
Bye-bye.
Now I would like to welcome back Dave, who will tell us more about finding the right doctor. Dave, the floor is yours now.
Thank you, Kath.
My first question is, how did you find a Parkinson's disease specialist?
Thank you, Kathrin. I began this process 3 years ago. I repeat, a lot has changed in Parkinson's information on the internet during this time. First, I will share what I would do now. Then I'll describe what I did then that is still useful. If my symptoms appear to be like Parkinson's, Huntington's, or essential tremors, I need to at least go to a movement disorder specialist for confirmation, especially if my primary doctor is not well versed in movement disorders. These specialists are neurologists with the abbreviation MDS after their MD designation. If my primary doctor doesn't know of a movement disorder specialist, I can ask someone in a local support group or someone that has Parkinson's. Another resource is the Parkinson's Foundation website. Go there, go to your browser, type in parkinsons.org/search in your internet browser. Find a section Expert PD Centers. Input your state, your zip code, and the radius of search like 200 miles. You will find the most complete listing of movement disorder specialists in our area. I was diagnosed by a primary physician as having essential tremors. My gut was telling me to keep searching as other symptoms were not addressed. I was talking with a friend with Parkinson's about essential tremors. She suggested I see a movement disorder specialist for confirmation. The movement disorder specialist diagnosis was Parkinson's. What I learned was make sure that my primary doctor is well versed in Parkinson's or see a movement disorder specialist.
Thank you, Dave. My next question is, beyond the neurologist, how did you find the right doctors for your team?
This can be a tough process. I looked at what symptoms that affect me, affect my quality of life the most. Non-motor symptoms can be significant. Some movement disorder specialists are well versed in non-motor symptoms. If my movement disorder specialist is not, then I need to expand my search for another type of specialist. I can go to the Parkinsons.org website to find which symptoms are Parkinson's related. Look down the left column for motor and non-motor symptoms. Look for my worst symptoms. I became aware that I was using my worst symptoms as a compass to guide me to a specialist I needed. I select my worst symptoms and read the page that describes the symptom. In some cases, there may be links to other pages with more detail. If a doctor wrote the article, I'll look for their medical specialty. That tells me what specialty might cover that symptom. If I have difficulty defining my worst symptoms, the internet has given me symptom ranking worksheets. One I found by Googling Davis Feeney Foundation, My Symptoms Worksheet, and look for My Symptoms Worksheet. Or Google PMD Alliance Empower Tool. Both these provide a process to rank my symptoms. When I left my movement disorder specialist 3 years ago, I did not have a list of possible symptoms. I was lost. One of my biggest resources was to Google Parkinson's and the symptom. I found papers for that symptom and read the summary or abstract. Most important, I looked for the type of specialist that wrote the paper. I then Googled that specialty in North Carolina to find the closest specialist. For example, for fatigue, I found website general information descriptions were written by neuropsychologists and movement disorder specialists. Googling revealed papers written by neuropsychiatrists reporting on research. With further Googling, I found a neuropsychiatrist in Chapel Hill with an office in Raleigh. He treated my fatigue. I still use this method to back check more general symptom descriptions.
How do you find if a doctor is a right fit for you?
In my visit to a specialist, I look for them paying attention and not being rushed. Do we have a conversational exchange about symptoms? Do we have a discussion about options for treatment with pros and cons? For my appointment, I usually read the symptom descriptions on Parkinsons.org and the results of my Google Parkinson's symptom search. I'm sensitive to the doctor being comfortable with me mentioning that on what I found. If the doctor seems intimidated or threatened, I will find another specialist. Finally, I'll trust my gut to determine if a specialist is right for me.
Thank you. Yeah, it seems like you're using the internet for a lot of this, which is a great resource. Yeah, thank you so much, Dave. Thank you so much for sharing, Dave. Now we're going to hear from our panelist, Diane Russell, who will share more about building her medical care team. Diane, can you briefly introduce yourself, please, for us?
Good morning. My name is Diane Russell, and together with my husband, John, we have made our home in New Bern, North Carolina for the past 15 years, since about 2006. In 2014, I was diagnosed with Parkinson's and retired shortly after that. For the past 2 years, I have volunteered with the Parkinson's Foundation to spread awareness of this disease and the resources available to people with Parkinson's and their families, such as the Aware and Care Hospital Kit.
Okay, thank you, Diane. And now I have some questions for you. The first question is, you said that discovering a center of excellence has been the best thing that has happened to you on your Parkinson's disease journey. Can you please explain a bit more what that means?
Sure. Well, you know, when you live in a small town or a rural area like Eastern North Carolina, you don't have access to a wide array of medical specialists who have a lot of experience treating Parkinson's. My primary care doctor did not recognize my growing list of symptoms as Parkinson's, but I knew myself that there was something not right, and I wanted to get an opinion of a neurologist. I was able to get an appointment with a nurse practitioner in that office who made the diagnosis, but I was never able to see a neurologist after trying for several months. So I went online and I started Googling. I learned about the Parkinson's Foundation and the Centers of Excellence, and I was thrilled to find out that there were 2 Centers of Excellence in North Carolina, one at the University of North Carolina, Chapel Hill, and the other one at Duke. So I called UNC and made an appointment with a movement disorder specialist. Finally, I found someone who understood what I was experiencing and confirmed the Parkinson's diagnosis. At my appointment, we discussed my symptoms, how Parkinson's was affecting my life, and treatment options. I learned the importance of building a team of healthcare professionals, doctors, and therapists with a movement disorder specialist as the primary Parkinson's expert. She gave me hope that there could be many more good days and years ahead. To be clear, you don't have to go to a Centers of Excellence to find a movement disorder specialist or a neurologist who is knowledgeable in Parkinson's. You can also find people with this experience in private practice, but usually they're also in the bigger cities. I hope that this program will inform and empower you to seek expert care, which I feel makes all the difference in the world. And this will give you a better chance to live a good life despite the challenges that Parkinson's has brought.
Thank you so much, Diane. My second question is, who are the other members of your medical care team?
Well, actually, my team is sort of located in two different places. So my movement disorder specialist, as I said, is at UNC. And so two other members of my team, primary team, are there also that she works with all the time. One was the clinical social worker in her office. And I found that the social worker is a very good resource, someone to talk to just once in a while if you need that, you know. And then she also is very good at suggesting resources that might be more in my local area that I could investigate. The other person on my team from UNC is the pharmacist at the outpatient specialty pharmacy. And I found that to be so helpful because she's right there with the movement disorder specialist, and she can get issues like insurance approvals resolved much more efficiently than I could. The other part of my team, of course, is in New Bern. I have a primary care physician. I had changed physicians now since when I was first diagnosed, but the primary care physician is the one who manages my general health, and he's very supportive and keeps abreast with what my movement disorder specialist is recommending. I also have a local neurologist who is sort of recently moved to town. And I go to him and, you know, we have a plan that he will track my Parkinson's care. And if there should be any type of issue that needs to be managed locally or an emergency issue, that he would assist me with that. He knows my movement disorder specialist, and so they, you know, can work together. I also have a physical therapist who's trained and certified in a number of programs for Parkinson's, like BIG and POWER and others. She's very good, and you know, it's just wonderful to work with. I also have a dermatologist on my team, and even though I haven't had skin cancer, I know that people who have Parkinson's are at increased risk for skin cancer, and so I make sure that I visit the dermatologist once a year. For fitness, also part of my team, well, I walk a lot through the neighborhood, and in general, try to stay active. I participate in 2 rock steady boxing programs, one in New Bern and the other one in Oriental, North Carolina. Both of them have very energetic and inspiring coaches and volunteers, and of course, a great camaraderie among fellow boxers. During the recent year, when we were confined more to our homes, our support group set up a virtual class with a yoga instructor. And you know, she is a well-known instructor in town, but when she's working with us, she can tailor her moves to our needs. And she's gotten to know us very well, and it's worked out to be a good class for us. The other program that I started to participate in during the pandemic, because it went virtual, was Dance for PD. And this is a program and founded by David Leventhal. And he and other professional dancers from the Mark Morris dance group in New York teach the classes. I also, as a result of that participation, started taking tap dancing lessons. And, you know, music plays such an important role, obviously, in dance, that I find that the dance sessions are just, I'll describe as joyful. So, and also, you know, they're fun. So I bet you didn't know that someone can tap dance when you're standing. You can tap dance when you're seated. You can tap dance with a walker, and you can just tap dance with your cane and top hat too. So those are great classes, and we have a lot of fun and get a lot of good exercise.
Thank you so much, Diane. That's really important information. So my last question for you is, how did you find all these amazing people and therapists and providers?
Well, sometimes that can be difficult. You know, ideally, you want to find someone who has a lot of experience in working with people with Parkinson's. And if they have additional training and certification, that is good too. Because these are the practitioners who will be most knowledgeable and will be able to tailor what they know to your particular case. So you might do as I did, either get referrals from doctors or from social workers, from support group members. You can learn a lot from exercise group members. You know, we talk a lot about who we see and who we like and who we feel listens. You can also call the Parkinson's Foundation helpline or go online. They have a lot of good resources and suggestions. And you can also go to different program registries. For instance, if you call Rocksteady Boxing or go online, they'll have a whole list of the people that they've trained and where their locations are. Same thing with LSVT Big and LSVT Loud, which are very popular programs in which I find a number of therapists now, quite a number of them are being trained and certified in those programs. And also, I can't leave out my Dance for PD. They also, if you go to their website or call them, they can put you in touch with a local program. So you don't have to do that virtually. I mean, in many cities you can do it in, you know, live in an actual group. So, you know, you never know where you're going to find the advice, just if you keep talking with people. And I think use the search on your on the internet, or call some of the National Parkinson's Foundations. They can make recommendations for you.
Thank you so much for sharing, Diane. And now we're going to hear from our next panelist, Steve, who will share more about his personal care team and how important the support of those around him has been during his Parkinson's journey. Steve, before we start, would you please introduce yourself?
I'm Steve Koetter, and I've had Parkinson's for 11 years now. I've had the Medtronic DBS implant, which controls my tremors. I have since developed dysphonia, a weak voice. My wife and I live just north of Fayetteville.
Thank you, Steve. So now I'm going to go to my first question for you. How did you find your support group, and what has that meant for you and for your family?
Set about trying to find information on Parkinson's when I was diagnosed. We came across a notice in the local newspaper about the Parkinson's support group of Fayetteville meeting. We found it a good place to get the latest info. We learned from the previous group leaders and have become group leaders ourselves. What we learned, we share on social media, email, website, and Facebook. We share also with family members and select friends in the hope they become more knowledgeable. The family is seeing us active in the community, which gives them some peace of mind.
Thank you, Steve. My next question is, what are the benefits of staying connected to a group of people who know what you are going through?
Support groups help you meet people who are going through what you are going through. And frustration, give and receive support, and exchange resource information and coping strategies. I believe in the statement by the Parkinson's Foundation, communication is key element in quality of life and positive self-concept and confidence for people with PD.
Thank you, Steve. I have one more question for you. That is, how can family members support loved ones with PD living in Eastern North Carolina?
With some knowledge of motor and non-motor symptoms, the family can find it easier to understand the person with Parkinson. Hopefully, family that has to travel stays in touch with you by personal visit or virtually or by phone tonight. It may be hard for the person with Parkinson to communicate by a number of these means, but keep trying. Many with advanced systems benefit from a set visitation schedule and yes or no question. Family should go along to medical appointments to ask questions, take notes, or share their unique perspective on symptoms or other issues that your loved ones may not bring up, such as sleeping problems or mood disorder. Keep a running list of questions to bring with you. Family can render relief to the spouse or caregiver by spending time with the Parkinson's person or the caregiver, allowing the caregiver some time of their own. Be patient. Persons with Parkinson's may now be slower at many things. Patience, please. Check with your county's Council on Aging office to acquire a list of services available in your area. Family members who are somewhat knowledgeable are less likely to be surprised by your symptoms. We recently read the children's book, Grandpa, What is Parkinson? By Maurice Jones to several of our grandchildren. It explained the symptoms of Parkinson and what children see in simple and loving words.
Thank you so much, Steve, for sharing. Now we're going to hear from our next panelist, Kent, who will share more about the support he's received from his local community. Kent, can you please shortly introduce yourself before we start?
Yes, my name is Kent Rosborough, and I've had Parkinson's for 14 years. Retired out of Fort Bragg, so I've been back and forth with the east part of North Carolina for quite a few years. I'm married for 48 years. We're kind of separated because we just sold our house, and so my wife's in South Carolina living with my daughter. I'm in Florida now, helping out my brother, who is working in New York, so I'm kind of watching over his house while he's gone.
Okay, thank you so much, Kent. So I have 3 questions for you. The first one is, so you just said you've had Parkinson's disease for a decade plus. How important is it to maintain involvement with your community? And can you talk more about your experiences?
You know, from your initial diagnosis all the way onward, because it provides a sense of, you know, giving back. You know, our active involvement and participation with others, it creates the opportunity to share all the special skills with the people who become lifelong friends. And it enhances our balance of life, and it reassures us that we're not alone with our journey with Parkinson's disease. You know, I started first involvement with community as a support group leader. You know, I eventually passed on that privilege, actually, to Steve, who just spoke. And by being a leader, I learned actually how to be a better member of the support group. And even though, you know, I told you, you know, I'm in Florida, my wife's in South Carolina, Steve is in, you know, Fayetteville, we still are part of that support group. And that's kind of neat. You know, Steve's wife, Nina, is, my wife is Diane, and they are the best of buddies, best of friends. And so that's nice too. You know, I've volunteered with other community groups, which I believe will flow into the next question.
Yes, exactly. So that's my next question. You mentioned community groups that are part of your support network. Maybe you can mention some of those that might be of interest to others.
Okay, sure. Yeah. You know, I can talk pretty much just from my personal experience. And the answer is there are many things, many groups out there. And I can talk maybe from the larger, bigger, all the way down to the local community. And I'll share some of those that I have volunteered with and in my kind of walk with Parkinson's. And you know, at the national level, we've got, you know, Parkinson's Foundation, and there is others too, you know, like Michael J. Fox or Davis Finney foundations. And those are so great a thing. And I'll kind of refer back to those in a little bit. And of course, I think we talked about already support groups at the local community. And I want to switch kind of a little bit because everything I talked about was Parkinson's related. And I want to talk about a tiny bit about organizations that are out there that also help me with Parkinson's. And one of them is the Cumberland County Council on Older Adults. And you know, each county I know has a similar organization. And I volunteered for them, I think, for about 2.5 years with the Senior Companion Program. And the gentleman who was my senior companion, we still talk to each other, but as we kind of went through that phase, I noticed that he started to shuffle, and that his hands would start tremoring, and that his when we were doing documents together, his handwriting very tiny, and so he's a former military, and so he went over to the VA, and eventually he got his 100% disability, you know, through the VA because he was Agent Orange Vietnam. So, but that's a pretty neat story. The other one is I volunteered for USO, and through there, just because by chance, when we were doing shifts, a couple of us noticed that we have Parkinson's, and you kind of notice that right away. And so it gives a good commonality. And even through the USO, they became members of our support group. Campbell University, you know, through their physical therapy program, it's very unique. Dr. Green and her students, they work with, you know, a broad spectrum of neurological, but also with Parkinson's. And so we would go up and volunteer there with our second and third year students. And it gave us an opportunity to talk to the students and teach them a little bit about Parkinson's. And by the same token, we learned a whole lot about physical therapy and that. So if there's a university that does offer physical therapy, it's so good for people like that have Parkinson's to work with the students. And it's nice to see them progress, from, their second year, third year, graduate. In terms of, speech therapist, I used to, and Steve has too, invite them to talk to support groups. And now is about the last 4 or 5 months, I noticed my speech is changing. I have to kind of think of the words. Up here, I know them, but when they come out, I have to really concentrate. And so I'm going to get involved with a speech therapist while I'm here in Florida and start that process. And for our veterans, the military has what's called the Parkinson's Disease Research, Education, and Clinical Centers, known as PADRIC. And the one for us that is closest is in Richmond, Virginia. And that's through the Army. They have all these centers through the United States. So that's another resource. But in every organization, I have met people with Parkinson's and people who have family members or are friends with the disease. But through the volunteering, the rewards have been very tremendous for me and have helped me in my walk with Parkinson's. And I think the final question is coming up, maybe.
Yes, thank you so much, Kent. Those are really great resources as well. Yeah, the last question is, and that's our last question for this session, is before we start the Q&A, is how do you manage to stay hopeful and positive in the face of Parkinson's disease challenges? Well,
this one, it requires some thought on my part because there's really no formula for it. And if you ask 50 people with Parkinson's the same question, you would probably get 50 different answers, and many of maybe the same too. So these are the things that I found to apply to hope and positivity. And they're, it's so I just started kind of brainstorming with myself, the first thing is I do understand that as Parkinson's progresses for me, there's going to be physical, mental, and cognitive changes in myself. And of course, I can see those changing throughout the 14-year period. But I know that, and so I kind of accept it. And I also try to remember, that there's going to be motor and non-motor symptoms that I have to negotiate. And that for me, they're kind of swaying right now because I see my resting tremors are increasing, and that, like I talked about my voice kind of in speech, and I didn't have those much before, but now they're much more present for me. The other thing is rest and exercise. Besides medication, I would say rest and exercise are they're necessary to lessen the complications of Parkinson's. And motivation, I think, is just as important. And so are balance and flexibility. And that kind of goes back to, working with the physical therapist or the schools there. Also, I found that self-study, myself learning as much as I could about Parkinson's, it's vital to help a person understand the basics of the disease. And so you always got to keep on, researching, looking, and learning what's the newest things that are coming about for Parkinson's. You have to know when to take your meds. At one time, I was on a big kick saying, nope, all you need is exercise and rest. And so when I went up to see Dr. Browner, I was kind of not cocky, but and I said, but this is what I'm doing. And I received one of the worst scoldings, nice, but scoldings of my life from Dr. Browner. And my wife and I love her. When we first met, her children were tiny, tiny. And now they're in high school. And but we love her till forever. And so she's been very helpful. But stay on your meds, take them when you're told to take them.
So, but that's very important. Let's see where did I leave off. Research. I did want to talk about research, and that's when I had the thought of, remember when I talked about at the national level, there was so much at the national level to coordinate research. And I know that, you know, I could tell them, I'm call and say, I'm here in Largo, Florida now. Is there any research going on in the area that I could participate in? Because it's in the end, you know, if we want to cure Parkinson's, find a cure, it's going to be through research, through our, you know, our doctors and our universities. Let's see. The disease for me, Parkinson's for me, and now we're inseparable. You know, I've had it long enough to, it's just a part of me. Yeah, I can't take it away. And so I just accept it. And it's kind of like, you know, being married for a long time, you know, you're just together. So it has changed my life completely, though. I will tell you that in a good way. I try to focus on positive thoughts, not negative. I think we should believe in our caregiver and trust them and thank them and help them to be caregivers. Sometimes for myself, yeah, I can be quite you know, ornery, you know, and so I gotta remember my wife is taking care of me, you know. I think small moments of greatness, they happen every day, and so I try to pull those into my heart. I think we have to know the resources that are out there to help us, so that are available to assist us. I think that gratitude and attitude, they work well together. Hope and faith, with a little bit dash of courage, it can go a long way. And we need to be patient and kind and be thankful.
Well, thank you so much, Ken.
Thank you.
Thank you. And thank you to you and all of our panelists. Now we're going to take some questions from our live web audience. Hello, everybody. Yeah, we're going to take some questions from the live web audience to our panelists. And I'm waiting for the first question. Okay, first question. Do you have any suggestions for managing your medical care team? So I think maybe Dave, you want to say something about that?
Yeah, there's one quick thing. One thing I have done is I make a list of the symptoms I have that are Parkinson's related. And for each symptom, I list 1 or 2 sentences at most about how the symptom has changed, if it has, in the last, say, 6 months since the last visit. If I'm seeing another specialist for a particular symptom, I list what that specialist is doing, like a medication change or something like that, and who the specialist is. And I view that list, I give it to each doctor before I see him at the beginning or at the beginning of the visit. And I view that it's my responsibility to communicate between the specialists. That's helped a lot.
Yeah, maybe Diane, you, I think you might have also some suggestions for that.
Well, yeah, I agree with what Dave said. You know, depending on what your symptoms are, you may wind up with, hope not a real big team, but, you know, a team of folks. And, you know, communication is key. And so I think that you just have to assume that either you or a caregiver, you need to assume that position to make sure that your whole team is working. So there's a few things that I would suggest. One is to have a list of who's on your team, who are the different people that you see, how do you contact them, that type of thing. Why are you seeing them? The second thing is, of course, you want your medication list, because it's a whole lot easier to just hand that to somebody in the office than to try to remember everything. Also keep I keep like a running list of symptoms, and not every little thing, but the bigger things that I want to focus on. And related to that, then I also keep another sort of running list of what were the primary visits that I had to, the different doctors or therapists, and what did we do, so that anybody could pick that up and kind of, get a running tally as to what were the important issues that you were addressing, and how is that going. And in each way, then when you, for instance, like when I go to see my primary care, I can say, okay, here's what I did since the last time I saw you, and just quickly run down it, and he's appreciative of that information.
Thank you, Diane. My next question is for Kent. So Kent, how do you think people with Parkinson's can contribute to help finding a cure for Parkinson's disease?
Well, there's many ways you can do that. One is financially in terms of giving to organizations, and but I think involvement with support groups is very necessary, and then volunteering like we're doing here with our Parkinson's Foundation. It's a good thing to do. But I think an important part is if we want to find a cure for Parkinson's, that we as individuals with Parkinson's need to get involved in research, clinical trials, and sometimes that's difficult because we might have to travel that long distance to a center of excellence to do that. But we can also do that, sometimes it's very easy, simple as maybe answering a questionnaire that our doctors and researchers are doing. And as Dr. Stacy and Dr. P, kind of the telemedicine, I am hoping that one day that I would be able to contribute to that research through the trials right here in my own home, so that we can do this virtually, and that it makes it much easier for an individual to contribute. And it's just finding that cure. I don't know how far away that is, and I don't know how close, but I do know that people with Parkinson's and their family members, this is the way we're going to find it, by contributing to research.
Thank you, Kent. My next question is for, sorry, Diane, do you want to add?
Well,
yes.
I was, being the only woman on the panel, I feel like I have to jump in here and just say a few words about women in Parkinson's. So lately there have been there's quite an interest into how women experience Parkinson's. We know that men are more likely to get Parkinson's, or when you look at the Parkinson's, people with Parkinson's are more men than women. But the questions are coming up as to, do women experience Parkinson's in a different way? Do they benefit in the same way from the drugs? Are there different drugs that may be useful? And why is it that women maybe get Parkinson's less frequently than men? Could it have something to do with hormones, changes in hormones or differences in hormones? So anyway, there's a lot of emphasis being placed on that now. And there's a couple, there may be more, but 2 studies that I'm aware of is through the Parkinson's Foundation. There's a study going on there. So I would say go to the website or call the helpline. Also, the PD Avengers they're doing a survey and hopefully developing some actions to take as a result of, related to women in Parkinson's. A couple other research ideas would be the PD generation research, that genetic research that's being done, that I think Deanna had spoke of earlier. Again, contact Parkinson's Foundation. And also Michael J. Fox has a very long-term program called Insight. And, you just answer a survey question every once in a while. And they have, I know a lot of the information that comes out of there are used by different research groups in their studies. So I think there's a lot of opportunity.
Yeah, thank you, Diane. There's also some research happening at ECU and at other universities. So if you look out for those announcements for research opportunities. My next question is for Steve. Steve, is your support group currently meeting in person or virtually?
We're meeting virtually right now.
Okay, and is that, do you feel like it's obviously it's still helpful, but are you looking forward to going back to in person?
Yes.
Yes.
I think we'll be both virtual and in person.
Oh, I see. Yeah, I think that's what's happening across the board sometimes. As a follow-up question for that, what are some of the ways you were able to stay connected socially during COVID from home? So maybe you can share some tips how you tried to stay connected.
Oh, we did quite a bit virtually. I read with the grandkids to help my voice.
And
Yeah, that's great.
Can
Sorry,
I comment on? Yeah,
yes,
it's
sure.
beautiful what he just said, because Steve and his grandkids, he reads stories to them, and it helps him with his speech, and it keeps him connected with his family. It's a very beautiful thing.
Yeah, that's great. I think the technology has given us so many options to stay connected and to share things. That's great. My next question comes in for Dave. So Dave, about how many specialists and healthcare professionals do you see throughout the year in addition to your movement disorders neurologists? And do any of them communicate with one another? We touched on that a bit today, but maybe it would be good to just hear an example from somebody.
I have 5 my internist, my movement disorder specialist, a neuropsychiatrist for fatigue, a neuro-ophthalmologist for double vision, a social worker, and all. The main communication, an example I'll give is I got into blood pressure problems that Dr. Stacy talked about because of Cinemed and taking blood pressure medication at the same time. And actually, when my movement disorder specialist picked up what the problem was, because I was sharing with him, he picked up the phone and called my internist to say, this is what we need to, this is where we need to keep his blood pressure above, knowing you want to keep it low. So there's an example where the movement disorder specialist stepped in with the doctor I would see more often.
Yes, thank you. Checking the Q&As. Are there any more questions? Does not look like it. And I think we're actually at the end of our program. So do you have one final tip, all of you? Is there one thing that you would give out as a tip for everybody listening or watching the video later? Maybe Dave, you are first in my video list. So maybe you can start.
Stay connected, whether it's support group, whether it's boxing, whether it's buddies, but with other people with Parkinson's, stay connected. We know each other. Is a talk I once heard, because we all have Parkinson's. I know you and you know me.
Mm-hmm. Thank you. Steve, do you have a final tip?
Yeah, get involved with the local educational groups.
Yeah.
The PT programs at Campbell and Methodist University and others that require actual Parkinson's patients to evaluate.
Yeah, that's a very good tip as well, to reach out and show up for things that you can do. Diane, do you have a final tip?
Keeping with the topic, I'd have to say that Parkinson's is a team sport, so I hope you go out and get a great team.
Yeah, that's great advice. Okay, Kent, you have the final words. Do you have any tips?
Yeah, well, one thing, when you're tying your shoes, make sure you don't tie the two shoes together because it's hard to walk.
That is
And,
an excellent tip.
And the other thing I think is, just to be very thankful and to be kind. And, like, a pearl is a tiny little thing, and when that's produced, it's done through a simple creature is like a clam, but it produces a kind of a gem. But to do that, it takes a lot of grit. And so you got to have that grit and thankfulness. And there is quality of life with Parkinson's. There is, you can see this for this whole presentation here, and people right here that we have on screen that they know how to just be together, to be together. Yeah, it's nice.
Beautiful. Thank you all so much for taking part in this panel. I really appreciate it. And yeah, I think we are switching over now to Diane or Annie, or both.
Hi, everybody. It's Deanna again. Thank you all for staying with us this morning for 3 hours. Want to thank the presenters, the moderators, the panelists for their time today. I want to thank the committee. As I told you all at the beginning, we've been spending months trying to figure out what is it that we really can present to those of you in Eastern North Carolina. Let us know your thoughts. A survey will pop up, so please don't turn off your Zoom yet. A survey link will pop up right when we're done here. Please complete the survey. You need to tell us how we're doing. So your feedback is very, very important. And remember that you will get a thank you email in a few days, and we're going to have a list of resources for you. So the resources like maybe support groups in your area, a movement disorder specialist, and others, that will be coming in a few days. Complete the survey. And I just want to leave you with the 4 pieces of advice that our PD panelists said. Get a team, be thankful and kind, have grit, stay connected. You are not alone in this journey. I'm here for you too, along with all the other volunteers for the Carolinas chapter, the helpline, and everything else. And get involved with others, with the PD family. Thank you. Take the survey. There's a lot of resources for you. Visit the foundation's website at parkinson.org, and have a great weekend.